Can you please play the CAHO anthem?
A new dawn, a new horizon of healthcare delivery and patient safety. We have a goal, a noble drive.
Hand in hand, step by step, we will thrive.
To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHOCON, your healthcare companion, standing right by your side. Joining hands for building a vision, shaping a culture for patient safety.
Setting up standards with best foot forward. Won't ever leave no stone unturned.
We wear our pride on our sleeves, work with passion like a breeze, train people, enhancing their skills, spreading the message of quality healthcare for safer patient care, a better nation.
We have a
We have a
goal,
goal,
a noble drive.
noble drive. Hand in hand, step by step, we will thrive. To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHOCON, your healthcare companion, standing right by your side.
Thank you. Please be seated. I invite Dr. Mahesh, Medical Administrator, Kaveri Hospital, Alvarpet, to deliver the welcome address.
அனைவருக்கும் வணக்கம். It's my privilege to extend a warm welcome to all of you to the CAHOCON pre-conference workshop on JCA 8th edition standard, jointly organized by CAHOCON, Joint Commission International, and Kaveri Hospital, Alvarpet. We are also excited to share that among the 31 pre-conference workshops that is held across the city, our workshop was the first to get oversubscribed. Reflecting overwhelming response and enthusiasm from participants towards quality and patient safety. As we inaugurate this session today, we are pleased to note that a concurrent workshop on AI in healthcare is happening in our sister concern in a Vadapal unit, which is also a JC accredited hospital. Let me take a moment to briefly introduce about the host institution, that is the Kaveri Hospital, Alvarpet. We started with a humble beginning in the year 1999 with a 30-bedded facility in a Tier 2 city of Tiruchirappalli, founded by 2 doctors with a vision to provide a world-class affordable care. Over the years, this vision has grown into a network of 12 hospitals with 2,250 beds and more than 8,000 dedicated professionals serving communities across two states of Tamil Nadu and Karnataka. Our journey so far reflects an unwavering commitment to delivering an exemplary healthcare with compassion and quality. What truly defines Kaveri is our culture. At the heart of it is a patient-centric care, where every decision is guided by what is the best interest of the patient. We uphold a strong culture of safety and ethical norms, ensuring trust and transparency in all that we do. We work together collaboratively in an integrated manner, getting support from evidence-based practice that align us towards the highest global standards of care. We are truly honored to have eminent panel of experts who brings a global insight and deep experience in healthcare quality and patient safety. I now take this opportunity to welcome our co-founder and executive director, Dr. Aravindan Selvaraj sir, who is also a practicing orthopedic surgeon. Dr. Ayyappan Ponuswamy, our medical director, who is also a practicing radiologist. I welcome Dr. Arjun Srinivasan, Deputy Chief Medical Officer, Joint Commission International. Mr. John Yoon, Managing Director, Asia Pacific, Joint Commission International. Mr. Nick Liu, International Manager, Asia Pacific, Joint Commission International. And Dr. Abba Sharif, Consultant, Joint Commission International. And the representatives from CAHO. Dear friends, you are all now in the healthcare capital of the country. You are also in the institution that represents a benchmark for excellence in healthcare quality in the country. I'm sure this conference today will serve as a platform for meaningful discussions, knowledge sharing, and practical learning that every individual will take back to their institutions. At this opportunity, I take this opportunity to express my gratitude to Joint Commission International for the transformative impact that had on our organization, elevating our standards of care, both in quality and patient safety, our operation excellence, and continuous quality improvement. With these few words, I once again welcome each of you and wish every workshop ahead. Thank you.
Thank you, Dr. Mahesh. I now invite Ms. Rashmi Srivatsava, Group VP Quality and New Initiatives, Narayana Hridayalaya, to share an introduction about CAHO.
Hi, very good morning. Welcome all of you for this program. And I think, as you mentioned, this was the first program to sold on with the maximum subscription. So I hope we can deliver as per your expectations from CAHO and JCI together. So my name is Rashmi. I head the group quality for Narayana Health. And just to mention that we were the first hospital in India also to go for an enterprise accreditation from JCI. So I know the worth of having the training and exposure with the JCI standard. But today I'm representing CAHO, not Narayana, as a healthcare professional division from CAHO. So I'll just give you a small introduction of what CAHO is and what all we do and how are we associated with multiple partners and what all we are planning to do in India. I think all of you are sure who knows CAHO stand for Consortium of Healthcare Accredited Organization. I'm sure most of you are aware, but just to let you know that it is consortium for all the healthcare accredited organization. So primarily we focus on patient safety, promoting accreditation, a lot of strategic thing with the hospital. I can't see. Can you, or can I have? Okay. And we do a lot of work in strengthening quality across India, and we have an international presence also in most of the country. And we try to do a lot of collaboration with other healthcare organizations to promote quality across the globe. Mission of CAHO. So primarily it is an association for healthcare institution, diagnostic services, individual professional, and the wing which I represent from the CAHO. That we have a lot of individual professionals who have become a part of this, and we try to bring capability and the training program also for those healthcare individuals. And just to mention very short that the CAHO has a collaboration with a lot of other organizations across the globe. CHRM, ASQA, LEADS, National Certification, SE Asia Joint Fellowship. So these are the organizations when we work together to bring the good standards in India and then make sure that the professionals who are working in quality and patient safety gets enough exposure, and then we meet the global standard. Coming to other forums, like, we have healthcare forum, pharmacy, supply chain. So usually you don't see these kind of large groups where we have collaborated professional across India for, startups, supply chain. Usually you'll have a focus for quality or patient safety group or doctors or nurses. But here you see there are a lot of focus given on the support services also, which includes pharmacy and student engagement. That is really very important because you are training the students of healthcare from the beginning. So they know about the standard, and then when they are in the profession, they can go and implement everything. So just to give you a little glimpse that how big is that organization is. So they have 2,600, basic programs, 700 plus programs, then 70 plus certified faculty. So we work in different hospitals, but we collaborate with CAHO and try to be part of a different programs to ensure that, we share our experience and knowledge with all others, and build that capability across healthcare in India. Again, the 20,000 training program has gone. 3,800 masters, continuing quality education, which is a very huge number, and then a continuing diagnostic services education, which runs by a diagnostic wing, and which is doing primarily lab, radiology, and a lot of other diagnostic programs. Then this is PREM, I think, the patient experience measure, patient reported experience measure. So a lot of the tools when we use in hospital comes from abroad. So CAHO has done a great job with collaborating a lot of professionals across India, and they have validated PREM for 17 specialty, which includes not 17 specialty processes, which includes your endoscopy, dialysis, and so on, and that is available for free. So if you want to implement in India, you can always download it and go ahead and implement in your process. In your hospitals. So continuing with stakeholders, we do the Spark magazine, which comes out in a monthly basis. It's a digital magazine, and I think it gives the entire update. Then there is a Friday update, which comes on weekly newsletter. A lot of hospitals are in collaboration with this weekly update, Friday update. So you can put in a lot of things about your hospitals, about even you can put your request if you want people and everything in this Friday update. Then there is a CAHO podcast, which is a monthly podcast, which we interview a lot of professionals across India. So again, organizing annual event, is a CAHOCON, which is happening now in Chennai, and CAHOTech and Diagnosticon. These are the three major events which happens on an annual basis. And again, SACCON is for the students, patient safety campaign, they keep running. Okay, this is just to tell you that, we have in healthcare institutions, or you're a diagnostic center, you're a professional collaboration. So anybody can join CAHO in their different capacity and get benefit out of it. So just to say thank you, and this is last year's picture which we have taken in our annual AGM. So just to tell you that how big is the thing, and this year it has become much bigger. So thank you for coming here, and I welcome you again from the CAHO and the JCI for this program.
Thank you, Ms. Rashmi. We will now proceed with the felicitation of our distinguished speakers and guests. To begin, may I request our co-founder and executive director, Dr. Aravind Selvaraj, to grace the stage. May I also welcome Mr. John Yoon, Managing Director, Asia Pacific, to join us on the dais. Thank you, Mr. Yoon. May I now call upon Dr. Arjun Srinivasan, Deputy Chief Medical Officer, Joint Commission International, to join us on the stage. Thank you, sir. To honor our esteemed dignitaries, may I now request our Medical Director, Dr. Ayyappan Punuswamy, to come forward. I welcome Mr. Nick Liu, International Manager, Asia Pacific, to the stage. Now I invite Dr. Abba Shroff, Consultant JCI, to step onto the stage. Thank you, sir. Now I invite Dr. Arjun Srinivasan to deliver the keynote address.
Good morning. I'll be very brief. Welcome to all of you. We are so happy that you're here. We recognize that you're taking a full day out of very busy schedules for all of you to come and be with us today. And we deeply appreciate that, because we know that what your presence here represents is your deep commitment to taking the best care possible of your patients, for keeping them safe and providing them the very highest quality health care possible. And that is what we seek in partnership with you. JCI's mission is aligned with yours to serve and promote the absolute highest standards and the best quality and highest value healthcare for all of our patients. So we honor your commitment to doing that, and we are privileged to be your partners in doing that. We view our mission as being one of collaboration with all of you. And so we look forward to spending the day with you here together. We have some presentations. We want this to be as interactive as possible. So we really encourage you to ask questions, make comments, help us know what's going well, where there are opportunities to improve. It's the only way we all get better together is through these types of interactions. So we really look forward to the interactive sessions with you today and the opportunity to meet all of you and to network and discuss. Want to thank Kaveri so very much for hosting us here. It is such a privilege to be here with the Kaveri team and an honor for us to be here in Kaveri Hospital. So thank you once again to our hosts at Kaveri Hospital. And with that, I will conclude and turn it back over, but we are looking forward to spending the day with you together today. Thank you.
Thank you, Dr. Srinivasan. Now is my privilege to invite our Executive Director, Dr. Aravindan Selvaraj, to address the gathering.
Yeah, very good morning to everyone. First of all, congratulations to the CAHO team. I was one of the part of the initial days when the CAHO was founded. And over the next several years, I couldn't contribute much to CAHO because of my various other commitments. And it's absolute pleasure to see CAHO has grown much more and beyond what the expectation of the initial founding team. I'm really, it's heartening to see not only the hospitals, the CAHO has expanded to diagnostic as well as the pharmacy and whatnot, every aspect of the healthcare. Congratulations to the CAHO team. And as far as our Kaveri as the group of institutions is concerned, Dr. Mahesh, our medical administrator, clearly explained our journey from a 30-bedded small setup in a tier 3 city of Tamil Nadu, where everything was difficult. From the pricing point of view, from getting the tertiary and quaternary care to that part of Tamil Nadu, it was a challenge. From there, we have grown significantly, thanks to the world-class quality professionals, both, are across all the spectrum of the healthcare, from doctors, nurses, the paramedics, everyone. We were very, very fortunate to have a fantastic team of healthcare professionals who are not only good at the time of joining, but willing to constantly get updated, and if there is any complications or adverse clinical incident, are ready to accept the fact, because the healthcare is one of the most intense service industry, which is problems are bound to happen. But unless always we go back and revisit where we went wrong, it is difficult for us to have reached this stage, earning the trust of so many millions of our patients. I always tell my fellow doctors and colleagues, I was in the UK for 15 years, and 6 years was my training program in orthopedic surgery. And every 6 months, I will keep changing I will be rotating under different consultants. Unless otherwise, I do one clinical audit project of that particular institution. Audit, I won't progress to the next 6 months of rotation. It can be as simple as something, an outpatient registration process to, or if you pick up a needle prick injury, either in the ward or in the theater, take it from there. And how we can keep on improving. That's the training I had during the early impressionable years of my medical career. So when we came back, and then how many of them, even the institutions like CAHO and all, brought the quality to the foremost agenda of any healthcare organization. And yes, we were ISO, QCI, and then later on, NABH also has become very robust now. And how did we think about the JCI for our institution? When we took over the hospital, one of the other hospital, from another group of institutions, our medical director, Dr. Ayyappan, asked me we should go for the JCI. I asked him why. Yes, we are doing well. We have grown. That's what we know. We are doing the regular audit in ABH. All the quality controls are there. But he asked, then how will the rest of the world know that we are in a world-class institution? So, and it had a bit of financial interest as well to that, because the international patients were coming, and then I personally went to Ethiopia to see patients, and then I could. They were asking, is the hospital accredited with any international institution? Then only I realized, yes, we should go further. We know it's not enough that we know ourselves that we are doing well, but everybody has to know, and then it has to be audited by everyone who can come and visit us, and then do an independent audit. So that's how our JCA journey started 3 years back. And then after that, we got the JCA for this hospital. And then the third hospital in Chennai also, we are going for a accreditation later this year. And if we all go by Dr. Ayyappan's vision, we want to get JCA accreditation for all our 12 hospitals in Tamil Nadu and Karnataka. And the journey with JCA, the 8th edition, when it came, I clearly remember we were one of the two first hospitals, one among the two first hospitals in India to get the 8th edition JCA accreditation. What was the other hospital, Dr. Ayyappan? Jaipur, yeah. So in the day, we were racing ahead, then saying whether Jaipur should get first or we should get first, the 8th edition. And the January it happened, isn't it? Yeah. So, and what was new about the JCA 8th edition, then I realized that sustainability and the technology, these were the two major chapters in the new, the 8th edition. And for the past 8-9 years, we have been very, very focused on how do we keep our hospitals or any healthcare services friendly to the environment. And I also realized that the hospital as the industry is one of the major greenhouse gases emission industry. People don't talk about that much. As far as one of the well-known international Danish energy company managing director is in our independent board, the hospital board. And based on his guidance and directions, we have been focusing for our renewable energy as the source of energy for our hospitals across the country. And then more than 90% of the energy that we use is from the renewable sources. And also the technology has been the major differentiator for us as Kaveri Group ever since 1999, where the computers at the early stage itself. And I'm glad that it's a privilege and honor to partner with JCA, and then we want to work with them rather than as an one-off episode coming for, okay, this year done, so 3 years later they will come again, we'll work for that, and then forget about that for next 2.5 years. We don't want that journey. We want to be part of our everyday clinical service because it is a 24 hours, never stopping organization at the hospitals. So we want to be associated with the JCA in that journey in India as well. Thank you, thank you. And I really warm, and then I wish them to have a fantastic session today. Thank you.
Thank you for sharing your insights, sir. And now it's time for the group photograph. May I request all the dignitaries on the dais to kindly come forward onto the stage for the group picture. And with this, we come to the end of the inaugural function. I sincerely thank the leadership team for joining us today. The stage is now yours, Dr. Shroff, who will take us through how to apply the JCI 8th edition standards across our hospital from standards to practice. Over to you. Thank you. Okay.
I know you were planning to see somebody else today morning, but I had to step in as he could not fly out to India during these uncertain times. Sorry. So, I just want to know before we start that how many of you work in an accredited, a JCI accredited organization? Okay. Thank you. Maybe having some exposure to healthcare quality and accreditation. So the talk today is pretty much focused on what is new in the 8th edition. One day is not enough for me to go through the entire manual, but I'll try my best to make this interesting and make this as informative as possible. So we will be going a few of the requirements and some of the revisions that have happened from the 7th to the 8th edition. Oh, I don't know why it's flipping on its own. Anyway, so for some of you who may not know who I am, I'm Dr. Abha Shroff. I'm a pathologist by training. In the days when we had an MD with path and microbiology into one degree. I've been working with Joint Commission as a consultant for the last almost 20 years. I have consulted with hospitals across Southeast Asia and Europe and the Middle East. I am well versed in the hospital standards and the clinical lab standards, and I also serve as a medical director of an ambulatory eye care center in Mumbai, which has undergone 5 accreditation cycles under hospital and ambulatory care standards. So I do understand what the Indian scenario is when we approach healthcare and quality. Right, so Joint Commission. intent as to why we are wanting that standard to be complied. And then we have something called measurable elements. And those measurable elements are 3 to 5 to 7 in number. And earlier we used to have something like either this element is met, it's partially met, or it's not met. But from the 8th edition onwards, we've done away with this partial met measurable element. So either you meet it or you don't. Now how do you meet it? If 80% of our observations are fine with that standard, we call that measurable element as met. Okay, so anything below 80% would be a not met. Or the standard is not applicable. So you can see a standard in the manual and say, oh, my hospital doesn't offer this service, or I don't do this. And so you have the opportunity to say it's not applicable. With me, everyone? Is there any? Okay. If there's any confusion, just raise your hand now. It's an interactive session. We have removed root cause analysis and sentinel events from a scorable chapter. So we're not, if you have a sentinel event, what is a sentinel event? Something that caused irreversible harm to the patient. Not intentionally, but it happens in healthcare. And earlier you were required to share it and do a root cause analysis. We now recommend that you do it. It's voluntary to share with JCI about the sentinel events in your hospital. There was a chapter called APR, which was called Accreditation Preparation Requirements, which is now scorable. So those measurable elements now will be scored, whether you meet them or not. Yeah. That was a brief overview, and I'd like to get into what are the changes in the 8th edition. So if you see, this is what I was telling you. There's a standard which is there in the top, like this is an example. Medical records contain patient profiles. So that's the standard. That's what we want you to do. And then there's an intent statement which gives you the background of why we want this patient profile in the medical record. And then these are called measurable elements. So this is what I was talking about. So there are 4 measurable elements in this standard, and you're required to meet with all of them. So 1, 2, 3, 4, and you have to, the way you comply with the standard is entirely up to you. So during the survey process, we will look to see whether all records have a patient profile, the hospital identifies what information they want in this profile, can it be easily accessed and is available to whoever needs it, and it is evaluated to see that it's actually accurate. So when you do a medical record review, you will check whether that patient profile is actually matching what hospital policy is. What is a patient profile? For those of you who are not across multiple visits, multiple surgeries, multiple procedures, and their files can be that thick if they're on paper or several sheets on an EMR. So we look for a profile that takes out the relevant information. So when he comes back on a subsequent visit, you know, okay, this is what he underwent. So you don't need to go through that entire file to know what's happening. So that's what we essentially mean by a profile. So the hospital can decide which patients need a patient profile and then what should be in that patient profile, right? The standard chapters have been rearranged. Nothing very dramatic. They're alphabetical now. That's all. Just to align with the Joint Commission, which is in the US. And so that there's a uniformity in us all. I'm still not familiar with the change, but yes, alphabetical makes it easier to know which chapter comes after what. The numbering has slightly changed. So you have this ACC.1 is like 01.00. Now we're also going digital, we're also going more and more online, and these kind of changes just help us digitize and make the process, the back end, easier for everyone. There is a icon now called D. Okay, there's a D in some of the measurable elements. Some of you who knew the 7th edition would know that there was a P, like a policy required at the standard level. So the main standard level, and sometimes measurable elements. But now the D symbol is only at the measurable element level. So like you saw those 4 measurable elements, now one of them will have, or there's an example here, sorry, yeah. So there's a D, can you see? On first, the hospital policy defines in writing minimum content for assessment. It has a D. So we want this to be in writing available. What is your policy regarding initial assessment of patients? Yeah, that's the D that I was talking about. The look back period. Now this is a big concern for hospitals. So if you're going in for accreditation for the first time, say today, we are in April 26, and you want to comply with the 8th edition of the hospital standards. So the hospital standards were released in January 2024. So you will have to show a look back period from the day that standard was released, okay? Say you started implementing it later, then we look for a 1 year or a 6-month look back based on for the initial survey, based on when that standard was released. Obviously, if you are 6 months after Jan 24, it will not be 1 year, it will be just a 6-month look back period, right? Now, if you're going for re-accreditation, the entire 3 years will be looked at. Earlier, we used to have a different timeline for that. But now when Kaveri Hospital goes for its next accreditation, so from the current one till the next one, the look back period will be 3 years. And Doctor said in the earlier this morning that we want JCI to be, don't leave us for 3 years. Don't worry, we've got that change in also. There's something called the JCI continuous engagement model. We'll be touching base with the hospital every 6 months to a year. So we're not going away anywhere. Like if you thought we disappeared earlier, we're not. Yeah. There are some edits in the 8th edition, like for example, the earlier one said provides an effective and timely resolution. Now we say effective resolution within a defined time frame. Because timely resolution meant it was left to you to decide the time, or may not decide, or what seems timely, but now we want you to define that time frame. So the requirement remains the same, but we are just changing the language in some of the measurable elements. The earlier edition referred to A to F in the intent, which was, people got confused, or it was not really clear. So now that A to F, whatever those bullet points were, they were removed from the intent and put into the measurable element. Because if it was in the intent, we thought probably people would think it's not in the measurable element, though it refers to the intent. Should I do it? Should I not do it? So to remove that confusion, we've put those elements into the measurable element, so there is no doubt about it, right? So that was a brief overview of the changes that have happened from the 7th to the 8th edition. So for those of you who were familiar, you know what's new. And for those of you who are new, this is how it is going to be anyways. So going right into the standards updates, I'll be focusing in the first part of this presentation on these 3 main chapters. 2 of them are new, and the information chapter has been realigned. Any doubts so far? All clear? With me? Okay, thank you. Today's day is going to be pretty much about standards and what they entail, and some of the slides will look like there's too much matter on it. You can relax and not take pictures if you want, because most of it is in your standards manual, should you have access to it. You're free to take pictures, but you don't have to get stressed about it that you'll miss out this, because most of it is there. The manual is really voluminous, so sometimes we don't end up reading the entire thing, and therefore this helps. Take out the bits and pieces. So if something strikes you that, oh, this is new, maybe I should do it in my hospital, feel free to take notes, but it's all there in the standards manual. So the new chapter that has been introduced is healthcare technology, comes under the managerial standards. And I'll be going into some of the new ones. Some standards in HCT chapter have been taken from the management of information. So you may notice from 7th to 8th edition, there's some standards have been moved around to make them, more meaningful to be in the area where they are now. So HCT 01.02. There'll be lots of numbers in the standards. We do not expect organizations to know the numbers by heart. It helps when you want to go back to see, but you're not required to memorize these standard numbers, okay? So don't worry about that. So we focus on telehealth. There's a new standard on telehealth, like I mentioned earlier. There's a new standard on how AI tools will support healthcare, and on cyber security and cyber attack management. So these are three new aspects in this chapter. The thing that we are going to look for in telehealth services, of course, how you set it up, that it should be uniform, no matter where the patient or the doctor is, you are able to provide that service. So if the hospital says, I'm going to give telehealth services for this, they should have a process written out. How are you going to give that service? How is it going to reach the patient? As seamless as possible with the technology available. Should you decide to give, say your hospital says, I will not give any telehealth services, then this standard becomes not applicable, right? Because then you're not assessed for it. But even if you do one teleconsultation, you will be assessed for the standard. So you may say, I don't do it, but when I go on to the wards or to the clinics and they say, oh yeah, we consult consultation all the time. So then we would expect you to have a process for the same, right? Even though you may have said it's not applicable to me. So what we will look for is, how is that patient information secure, confidential, and more importantly, how do you integrate it into the medical record? Because it's happened electronic, the patient record, because that will be what the next visit they will refer to, right, for the findings. And how well are your staff educated and trained to provide this service, right? So we will be looking for these aspects. Regarding artificial intelligence, now everyone comes to my hospital to sell the software and saying, oh, AI can do this, AI can do this. And it's really tempting, because somebody said, AI can take over your reception, doctor. You don't need to employ these people to take phone calls. AI will do everything. Sounds great, because it saves me, 10 people's salaries maybe to give out at the end of the month. But that's not what, I don't think healthcare can be completely AI dependent, yes, but you can use tools. So JCI is not saying don't use AI, but if you do use it, then there are some standards to comply with. So firstly, you should have a qualified individual to select the AI tool that you want to implement in the hospital. Should be multidisciplinary. Everybody should agree that we're going to use this AI tool. How do you approve and implement it? You cannot do away with human physicians, so you will need somebody to look at it. So we had a software person who came in and said, you can put all your ophthalmology findings and the tool will give you a differential diagnosis. I said, oh my God, what's going to happen to our brains then? That what we've been trained as doctors to do. But he says, no, they'll give you and then it's up to you whether you choose it or not. So should the doctors decide that they want to use it, then they have to get approval, know how they're going to implement it, and the final decision will have to be the physician in that, if it's a differential diagnosis. Again, security, privacy of patient data, because the minute we go online, everyone knows. Like sometimes when I'm talking, my Instagram will start showing what I was talking about to a friend, and I'm wondering who's listening to me. So, so if you're going AI, telehealth, you don't know who's listening. So, what is your robust patient information security and confidentiality? How will you analyze whether this AI tool that you have implemented is actually effective? So you take feedback from the stakeholders. How do you update the software? There are a lot of ethical considerations also that come in, and so we would like to see this as a, as a hospital-wide agreement to use that AI tool. It may work for other industries, but healthcare is a sensitive, multidisciplinary, as all of you know, dynamic. Every day, every morning when I go to the hospital, I think this is the way the day will go. And then suddenly something will happen that has never happened in the last 30 years of practice. And then again you're thrown and go back to wonder, how do I handle this? I'm sure many of you would have experienced that. It's a very dynamic thing. No 2 days in the hospital are the same, you know. And of course, we have to see what are the outcomes of these AI tools, whether we need to change them. So there is a whole standard focused on AI. And the other new standard in this chapter is on cyber attack and cyber risk management. Imagine if your Wi-Fi, internet, cable thing got a cyber attack. I think we'll have to shut down the hospital, because how will we function if we are electronic? And those are the days, my older staff comes and tells me, see, madam, the paper was so much better. The computer has, given up. The cable is not cut. Like, that's what's happening between both my clinics just now. The cable provider, there's some repair going on, so one hospital cannot access the patient data to the other branch. And we're struggling with it for a week, and several times I've been told, see, it should be separate, see, it should be like this. But we have to move with the times, and we have to know how to handle these problems when they come up, right? So, what is the communication for EMR? Is there something that goes primarily on paper and is transcribed later? So the hospital needs to decide and come up with a plan. Should something like this disrupt the service, what is our action plan? We are not saying everything needs to be, on paper. You decide. These are the backup, right? So that's where everyone gets involved in it. And basically, we have a list of things that could be vulnerable to cyber attacks. We have a list of things that could be vulnerable to cyber attacks, like your lab, scheduling appointments or OR lists, and any other, your medication prescriptions if they are online. All these things have a risk. So firstly, how do you prevent a cyber attack? So you have to have a robust security system. But should this event happen, now you may say that in the last 5 years there's been nothing like it. But that's not to say that it's not going to happen in the next coming 5 years, right? So you have to be prepared for any eventuality that may happen. So that's about the healthcare technology chapter. We'll have a session for Q&A, but if there's anything burning question for HCT, I am happy to address it. Okay. So we go on to the MOI, or Management of Information chapter. This was existing in the 7th edition. Some of these have found their way into HCT. Okay, so you may see a difference if you are comparing the two editions. MOI 0102, okay, so ransomware cyber attacks has found some, so the parts that are in red on this slide are the new additions or modifications. I've tried my best to make it as easy as possible to understand. So the language has shifted, but the parts in red is what has been added on. So ME2 has been expanded to include cyber attacks. ME5 is a new measurable element that says you have a written policy with procedures to follow in the event of a successful cyber attack. Okay, so how are you going to manage it? So please don't think that you will be safe. The more branches you have, the more interconnectivity between hospitals. This is a thing that can happen in the future, and nobody, believe me, nobody is above it. We keep reading in the papers about healthcare so far, not so much, but there's nothing to prevent some person sitting in the dark web somewhere to just have fun on one Monday morning and really upset our lives. So we should be prepared for it. Okay. ME3 of this standard is new, where we want the hospital to show evidence of staff being trained for this. Like today, you and I may know what cyber attack is. Some of you may have not heard of it, or some of you are not aware of it. But whoever is using one of these information systems needs to know what is a cyber attack, what is a phishing email, what is a spam email. Many of us have organization emails, right, that we check every day. And we receive emails, and sometimes you get an email that looks like from the hospital management, but it is not. It's some kind of malware or something. So staff need to be trained to recognize these. So many organizations are doing it all over the world in India, and we want the hospital to demonstrate that staff have been trained for this. So you can train them. An example is, how would you train? You say, how do I train my staff? So you put it into the orientation or the 6 monthly training or update in training, and then you say that now you start reporting these, and then deliberately send like a phishing email to know how many staff actually reported it back, that this was not actually email, it looks like come through our own organization. So that's a good way of training and seeing whether they know, right? So the survey process will look at this standard, saying how this training was given. Your training can include topics like this, like password protection. Like, I get irritated every time I get an email from the organization I work for that now your password is going to expire and you have to change it. So earlier, and you cannot use, have you seen that? You cannot use the last 10 passwords. My God, I have to write down that password to even remember what that, and that's the most, I don't know what to do. So this year, you know what, I'm changing the password to all the Indian festivals. I said some Ram Navami went, something went. Make that into your password, because how do I know how to create passwords? Oh my God, now everyone might think.
Sometimes there are criteria like
Exactly.
this and that.
You have to have a capital letter, you have to have a small, you have to have some kind of a symbol, and then you have to have a number, and none of your personal data. So after you're done with all your children's names and your extended family names, you can move to festivals in India. We have so many, you can change it, right? So how are you trained for that? How do you train your staff, and how do you report suspicious activity, like I said. So these are the brief requirements that have been added on to the MOI chapter. Now the MOI chapter still has plenty of other standards, mind you. These are not the only 2 or 3 ones. I am only sharing the ones that have changed, okay, or that are new requirements. So it has its own everything else. If you are already an accredited organization from JCI, everything that you're doing still continues. We are just adding on and changing things, right? So don't think that those are lost and gone. Okay. So that was the changes in MOI, and now this is another new chapter that we have called the global health impact. Now everyone talks about climate change and how it is environment sustainability, and what is all this about? Okay, so how does accreditation and sustainability get together? Right? So what we are looking for is how hospitals are going to commit to some kind of environment sustainability. In fact, in COVID, I thought all the environment sustainability went for a toss, because the amount of disposable equipment that we used, in fact, whatever we were saving for the last 10 years, I think in those 2 years we matched up to it. So there are situations where you will not be able to be sustainable, but those are one-off, not on a regular basis. What is the best way to reduce carbon? What is the way the leaders will show that they have achieved environmental sustainability? So it's not going. Oops. Don't tell me this is a battery. Decided to restart. Sorry, just give me 2 minutes. Just decided to reboot itself. That's weird, I know. Sorry about that. Technology. Oh, it's fully charged actually. It's not about that. Sorry. It's fully charged, so I don't know what happened. If you want to. Oh, sorry. Okay. Price of technology. Okay. Give you all a brief break. So the JCI sustainability standards have come from a partnership with the Geneva Sustainability Center and has been included into the 8th edition and the survey process. So there are 5 areas basically where we will look for compliance with this chapter. How the hospital leadership is planning, tracking, reporting, how employees are engaged, the use of green resources, how the supply chain can comply, and the infrastructure and resilience. So these are the 5 standards in the GHI chapter. So it's a new thing. The question is, oh God, how do I begin to comply with this? So this is a very brief overview that strategies are included and acted upon as part of the hospital's operations. How are employees going to be trained on climate change and health? How do you come up with that? How are you going to reduce the use of materials and resources? Actions to reduce the impact on supply chain and to identify areas to reduce unnecessary use of supplies. So one has to do an audit or an assessment in your organization to know what you could reduce using and how they may affect services. So in the survey process, this is how we will look for things. So these are a few tips on what we will look for in a survey process. It is not limited to this, may not be all of this, some of it just to get you going. Is we look at the board agenda. Did the board, because it's not enough for you to tell me, oh yeah, we have looked for climate change and we have seen the impact and we have implemented. But when did you discuss it? What did you do? So the minutes of the meeting could be one of the things that would be looked at. In your annual report, a progress is shared. Okay, we were like this here and we are now at this level. Employee orientation can have a module on unnecessary wastage of resources and materials. A measurable, written measurable plan is what we're looking for. Like, what is your target that you want to reduce waste by so much or reduce carbon emission by so much and by what date? So a written measurable plan. Regions have the same hazards as I may have. It's different for every place. So it's been a real pleasure for me when I've gone to hospitals all across such a wide, so many countries, so many cities, and everyone's hazard is something else. Like I was consulting online with a hospital in Russia. This was some years ago before COVID. And I'm like, what are the hazards that you're looking for in the climate? I would think like any other city, it's like traffic or it's like snow or it's like. So they turned around and said, no, we are looking at disruption in water supply. So I said, why? So he said, no, we have these canals that run next to our thing and something could, if they break or they, get flooded, we will not get water and all. So I said, oh, that's unique. So they had actually thought of the climate. So every place has a different hazard that they can face, So, and what we would look at triennial surveys is that you did an assessment of the environmental risk scenarios, vulnerabilities conducted every 3 years. So once in 3 years, we want you to re-look at what you had seen in this chapter. So I know it's new, it's complex, it's not easy to understand, but accredited hospitals and even non-accredited hospitals have access to get the survey process guide. So JCI, if you all know, has a standards manual and also has a survey process guide. The thinner version, which often I see in hospitals, they don't look at it much, but it gives you a very, very clear view of how your survey will go. And if you really go through that process guide, it gives you what kind of questions will be asked, what kind of sessions will be held, what is your agenda going to be like. And it's a great way to prepare for a triennial or an initial survey. So I would strongly urge all of you to get access to a copy of the survey process guide along with the manual. So you know that this chapter will be addressed like this during my accreditation survey. So it just helps you prepare for it. Now this was that first half of this thing, so I had like a 15-minute break, but I think our break is at 11. So shall we stick to 11? Right? Okay. So ignore this slide and we'll just move on, because I thought it'll take me that much time to reach here. But you all are a very engaging audience, so it's going quicker than I thought. So we'll break at 11 as planned, maybe in the middle of this presentation. So we'll just stop when it's 11 so we can have a 15-minute break. So this part of the presentation is going to focus on primarily these three standards: facility management, government leadership, direction, and staff qualifications and education. So these chapters were there in the seventh edition. They've always been there since my hospital got accredited first on the 3rd edition of the hospital standards. And then we shifted to ambulatory care. So then we underwent the 2nd, 3rd, and the 4th edition of the ambulatory care standards. And I have been consulting and training with hospitals on hospital standards since the 3rd edition. So I've seen, so these chapters were there even then. Going into facility management and safety, this is like a, I wouldn't say worrisome, but the chapter that gets the maximum findings, whether you like it or not. It's a chapter that has many standards, so naturally there'll be many more findings, but nothing that is, earth-shattering or difficult to comply with. And primarily that's the reason, because in our country we have different regulations from state to state, from region to region, and therefore this facility management becomes a very important part of the hospital, because unless our facility is able to provide that infrastructure for safe healthcare delivery, it forms a very integral part. So one may say, I am treating the patient is alive and kicking, going home today, I don't care. But you need this infrastructure to be functioning efficiently for you to be able to provide that healthcare, be it from a security system, a CCTV, access of doors, there's medical equipment, safety of patients, so much of hazardous waste that we produce. Everything needs to be managed, right, to be able to give that optimal healthcare delivery. So there are 8 FMS areas, like over safety, security, hazmat as we know it, fire safety. We see so many instances of outbreak of fire in hospitals, and it's really sad to know how patients lose their lives to provide safe evacuation. Equipment, then the utility systems, all your gases, your water supply, your drainage, there's so much of utility that we use. Our emergency rooms, whether everything is functioning there. No hospital does not undergo construction or renovation. We want to expand our units, and we have to do that in a functioning hospital. Believe me, the greatest challenge we have in a hospital is when we want to renovate or extend something. We can't shut the hospital down, right? Just so that. So how do we manage that construction and renovation, right? And so this is the focus of the FMS chapter. And what we are looking for is a written program for each of these. Each of these chapters, how do you have a written plan to manage this? Okay? And all these chapters, all these standards have a detail of what we require you to have via the intent and the measurable elements. So your facility team can sit with it, go through, and I will briefly just tell you the main changes that have happened in some of these chapters. So in the safety program, it pretty much is the same, except that there is a now focus on workplace violence. Okay, we do have violent patients, but we have violent staff members, we have violent vendors, we have anybody can create a ruckus in our facility, and no hospital, believe me, is above workplace violence happening. So what are the safety risks? So you see in your city or your hospital, if you've had past incidents, you see if there are incidents in other healthcare facilities, and then conclude how you will prevent this from happening in your own facility. You know, that's the way to approach it. It's a preventive measure. See, when it happens, the incident has already happened, so then you will know how to handle it. But how do you prevent it from happening is what healthcare accreditation, quality, patient safety is all about, is to prevent these errors or these situations from happening. So the 8th edition is looking at workplace violence very closely to know how they are going to, manage these. So you look into the safety incidents that have happened involving patients, staff, others, anybody in the facility. And based on this investigation and reporting, you find out the cause of this incident or this situation, and it could involve anybody. Patients, it doesn't have to be only with patients, it may happen with staff, it could happen with other people in the hospital. And how are you going to mitigate these risks in the future? So this is one important area that has been added on to that FMS standard on safety. The next standard I'll talk about is on security, the security chapter. So safety is one, security is another. There's a difference between the two. Okay. What are the areas that are, have a security risk? I was in a hospital abroad where, the infants that are born, they have a tag on their ankle, and if someone, to prevent infant abduction, and if you go with that baby even near one of those exit areas of the ward, something starts beeping. So I remember my sister-in-law delivered a baby, and we are so excited with the first baby and all. And I was in the US, in Atlanta actually, Arjun, from where you are. And the first thing the nurse said, walk with the baby, but don't go beyond this because it'll look as if you're abducting the baby. I said, oh my God, really? Maybe that's an expensive way of doing it. Here we'll have a guard standing there to see who's there. There we don't have so much labor. So there are various ways in which the facility is made secure. Okay, like no access to terraces, windows are locked, etc. So how do you monitor these areas of security? It involves everyone: patients, staff, students, trainees, contractors, volunteers, name it. Anybody who is in your facility, you are responsible for that person, safety and security. Okay, so it's not that somebody just visits once a month, so he's beyond the scope of that. So you need to, even you may have shops and businesses in your hospital. Some hospitals have a florist shop or a cafe or something which they don't manage, but they also become our responsibility. Okay, so there are 3 new measurable elements that have been introduced into this standard on secure environment. All security equipment and systems, how do they detect, record, do they have alarms, how are they inspected, evaluated, maintained, right? How are relevant staff educated to comply with these requirements? And how do you conduct certain exercises with staff to evaluate whether they've understood what this program is, and what to do in case there is a security risk, whom do you inform, what do you do immediately, what do you do later, what do you do analyze later. So we want a very robust, plan to have a secure environment. So there are lots of measurable elements. There is an annual analysis that the hospital would be required to do, and added on to its workplace violence program. And how do you investigate these security incidents that may happen? Okay. How are staff trained to prevent them from happening? And based on these incidents, you have to report it to the governing body or to the staff or to your annual report that this is what happened, this is the changes that we've done. And so no change that you bring about in your hospital should be just because somebody wants it. You analyze why you want it. You analyze, prove to everyone this is required. Tell them why it is required. And then see that the change that you make is sustainable. So it's very easy to buy a piece of equipment and install it, and then you suddenly realize, oh, there's nobody to service it, or nobody knows how to repair it, and then you're stuck after a couple of years with it. So see that you can sustain the change that you make. For all the standards that you comply with, change must be sustainable, otherwise it has no meaning. Otherwise staff tend to think that, oh, today they've decided to do this, tomorrow they'll do something else. We've been in those situations in the past. But as we go on our journey to healthcare safety, patient safety, quality, these things become a part of the culture. So I was just reminded that what did we implement in our hospital? And I said, why are we doing this? And nobody wanted to, I'll talk about it in IPSG, nobody wanted to implement that change, okay, even though I was very convinced. And when we implemented it, the patient came and said, oh, thank you so much for making this change in my pre-operative checklist. I'm so grateful. And after that, all doctors, nurses, everybody was agreeable to do it, So change has to be welcomed. It should not be feared. Very often when we are told to change something, we don't want to because we think it's fine the way it is, right? So it's that PDCA cycle that comes, you plan, you do, you check, and then you act. That's what quality people will understand, PDCA. So you check in a small sample and see, and then you act upon it, okay? So all these are new standards, new measurable elements. So treat cautiously. That's all that I would like to say. Don't implement everything overnight. The other standard we want to talk about is hazmat, hazardous materials and waste. So during the survey process, we will look to know or ask knowledge about handling hazardous waste and managing it, okay, based on their role and responsibility. So if those of you have undergone a survey process, we even chat with the housekeeping staff, or we chat with the person standing at the door, or with the newest nurse on the unit. Those are my pet people they tell you the real story. So if I go to a hospital and they all disappear, I actually ask for them because, these people tend to hide somewhere behind the doors. And I don't go for surveys, I go for consultations. So basically, we prepare the hospital for accreditation. So I tell them anybody and everybody should come and talk to us, don't hide behind the doors. And I just make the housekeeping staff feel very important. And that's where all the information comes of what is going wrong and what is not working. And, sometimes it's good to chat with them. So you know exactly whether your systems are being followed or not. Of course, you don't want it going wrong during your actual survey process. But while you're preparing, involve everybody who has anything to do. If we're talking about hazmat, anybody who handles waste, cleans, spills, exposures, talk to all of them. And when you're putting that change in, ask them whether they're going to be able to do it, or ask them for ideas, what is a better way of doing it. And you'll be surprised at the simple solutions that will come your way. Instead of sitting in a room, some of us, and thinking this is the best way to handle it, I often go to the bottom person in that area and ask them that what would you do, and is this better or is this better, and they will tell you. Sometimes it's a new disinfectant that you have introduced because you read about it, we read as leaders, this is very good, and then they'll tell you, but do you know it leaves a stain every time we use it? You say, oh my God, that's not acceptable, right? So involve this baseline staff in everything that you want to implement in your hospital, right? So you are also required to identify the types of hazmat, the location, the quantity that is generated, because you may be generating a lot and then you don't have a place to store it. Can you imagine? It's all spilling over. I was in a hospital once where I was in the microbiology lab. Very few quality people visit the lab because they think it's in some part of the hospital which is taking care of itself. We are only concerned with the report that comes on the system. But I went into the microbiology lab and, you have culture plates. Some of you may know. We culture bacteria right? And then after they are reported, they are put into this hazmat bag and they have to be disposed. The bin was so small. So I said, is it today that you have so many plates? He says, no, every day, but nobody's changing the size of the bin. So it spills over, and those are live cultures, right? You know how infectious they can be. So a simple change had to be done is just provide a larger bin so that all those plates are secure till they leave the facility. That's it. There was nothing dramatic to be done. But until you go to the area and see where the waste is being generated, you cannot find solutions, right? And as those who have undergone a survey, the survey team goes anywhere in your hospital. You cannot say, you cannot enter this. You cannot say that this bathroom is only for this thing, so you can't inspect it. No. We can go to any part of your hospital and check it, right? So you should know how much you generate, where is it stored before it's taken away. All waste does not leave the hospital every day unless it's very large. There are storage areas because there are agencies, I think, that come in many cities to collect that waste. And they are not going to be there all the time waiting to collect waste from your hospital. So it takes time, right? And then when you have this inventory, you have to look at it every year because then you may have changed, you may be generating more waste somewhere. How are you managing it? So it's a very critical part, and we want to know how staff is trained to manage it. Moving on to global communicable diseases. So these are new MEs that have found their way into this chapter, into this standard on hazmat. All of us have experienced a global communicable disease. So about 10 years ago, we used to theoretically talk about a global communicable disease. And we have all experienced what it is. So many people said, oh, this happens once in 100 years. The last one was the Spanish, some plague or whatever, and now it's this. There's no saying. And then there was people who said, we will not be living for the next 100 years, so it's okay. There's nothing to say that it can't happen again. So we want hospitals to be prepared. We've already learnt lessons. Just keep them going. What worked for you during the pandemic, just follow those protocols. See that if this were to outbreak tomorrow morning or the next week, you are equipped to handle it, right? So how do you activate your management procedures? What are your communication strategies? The key thing for hospitals was alternate supply chains, like something that you're so used to having is not available. So what are your critical supplies that you need? Will they last you for how many days? How much capacity do you have to store? We are looking for compliance with these measurable elements in that respect. emergency staffing plans. Many of us either didn't leave our facilities or we couldn't enter our facilities, right? So what do you do in an emergency? What points of patient entry will you block or allow to happen in case of an outbreak? Test your program annually, revisit your documentation and see, okay, has anything changed the past year that I need to change in my plan? Based on this annual assessment, what are the follow-up action points? There may be none, or there may be one, or there may be a few follow-up things that you need to do. And suppose you get a sudden influx of patients, how are you going to manage them in your facility? Because as healthcare providers, we don't normally say no to a patient unless we don't have the expertise to manage them. Then we find an alternative place for them to go and proceed with their treatment and care. So how do we manage this influx of patients, right? Yeah, so I think that's pretty much it. There is something in the facility management system tracer that we have, which we call as tracing the system. So for those of you not familiar with the survey process, there is a separate surveyor for the facility, which will not be the physician or the nurse that visits your hospital. And they love to visit. I don't know, when I talk to my colleagues, I have done it couple of times also. We double up. We are all trained to inspect all parts of the facility. So the minute I enter any facility, my eyes start looking, So when I came in this morning, and I was standing next to Nick, and I just said that, just tell me to stop looking around, because that's what we are trained to do. And we suddenly start looking. Nothing is wrong, mind you, and when I came in, but your eyes tend to look everywhere, and the tracer normally begins at the top of the hospital or at the bottom, at the terrace or the basement, wherever we feel like going. One of the best tracers I did was in a hospital in Tokyo, because we went to the terrace, and I was doing that part also in that hospital. Even though I'm a physician, but we are trained to look at the facility. And they said, oh, we have the helipad up there. And I said, okay. And I said, what do I look for in the helipad? How do the helicopters land for air rescue and all? And the best part of it is we saw this Mount Fuji on top, from there. So instead of looking at the survey, we're looking at that. So there are exciting parts also in the survey process. And it was one of those clear days where you saw, I didn't get a chance to visit the mountain, but the facility tour. And then it had 3 basements below, because Tokyo, is like Bombay, there's lack of space. So you go vertical or you go down. There are 3 levels of utility systems, waste management, which went basement 1, basement 2, basement 3, all managed very efficiently, how the waste comes. They used to even recycle, the infant diapers of stool and urine. So I said, what do you do with this? He says, no, this is called environment sustainability. They used to take those diapers and they would all come through some chute. Then they used to get disinfected, because it's all infectious waste. After that, it would be converted into fertilizer. I don't know what machine they had. And then there are these fertilizer packets for sale. And if you're a staff member who took it, you could take it for free and grow in your garden or wherever you wanted. I mean, I had never seen recycling of waste to that level. So there are, not to say you have to do it, but I'm saying people do it. That's how they manage. So these are the things we come to see in a facility tour. There are lots of, things that we learn, how hospitals manage their facility. And so what we will look for is all these areas, and all these areas will be assessed during that tour. So it starts with a tour, then we see documents and that facility system tracer, depending on the size of the hospital, can last over almost 2 to 2.5 days. And I often find my colleagues, even till the last day, they are still reviewing documents, interviewing staff to know. So I'm just sharing a bit more because it's a very important part of this accreditation process, having a robust infrastructure and facility to support healthcare delivery. Okay, so we go into the third chapter of this section called Governance, Leadership and Direction. So it's called GLD. Many of the standards are quite what they were. Some have been introduced, some have been removed. So this is a new measurable element that has been added on to this GLD 3.01, which talks about provision of uniform care. So all across the hospital. So if a particular care or treatment is given in an emergency department or in certain common areas, there will be a uniform way of assessment and providing care to those patients. Of course, not dependent on day of week, or you can't say it's Sunday, so I'm going to cut down some part of the initial assessment, or it's a holiday, so there'll be a leeway in the after some of time frames. No, we were looking for evidence of uniformity of care, no matter what day of the week it is, or the time of the day it is. How do you see how acute the patient's condition is, and see whether you have the resources available at that time to treat the patient. And it's comparable throughout the hospital. So we want to see, and we will be assessing how this uniformity of care is given to patients across the entire hospital. There is a new ME in the Quality and Patient Safety Program Standard. You are required to define in writing patient safety events. Even though we are not assessing sentinel events, we want the hospital to know what is a sentinel event for that hospital. The reporting of sentinel events, like I said in the very beginning, is become voluntary, and you can contribute that event or the way your analysis to a it's like a program that we have for database reporting, but that is now. How do you provide support to staff that have been involved in an adverse event? We don't realize it, but any kind of event that happens to a patient not only affects the physician, but affects everyone that provides care to the patient. Sometimes it's the death of a patient, or some irreversible harm has happened, and it does play. Everyone thinks, in hospitals we are very involved with our patients. It's a service that we give selflessly, and we don't know that we are that involved with the patient. So when something adverse happens, whether we like to admit it or not, it does affect us at all levels. So how is the hospital providing support to staff that are involved in this kind of an act? Sometimes it is our fault, sometimes it is a factor beyond our control. It could be anything. An adverse event is an adverse event, is something that unexpectedly happened to a patient, which you were not deliberately wanting it to happen, right? I don't think anyone in the healthcare business wants to deliberately harm a patient, no matter at which level we work at. But things happen, which is beyond our control. We're dealing with human bodies. They are dynamic. Someone reacts, somebody doesn't react. Sometimes you take all the precautions that you could, and still something goes wrong. So it does affect staff. And is the hospital having a system where staff can reach out to, if they need support in that event. So we will be looking for evidence or ability, or staff should be able to say that, okay, if such a thing happens, then this is what I will do, or this is who I will reach out to, or this is where I will seek help. Again, this will come into the SQE chapter, where the staff mental health is another aspect that we have introduced in the 8th edition. One of the standards is on the use of data. So we would like to see that the hospital-wide priorities that you said are based on data. Like, why did you decide to monitor this? Or why did you decide to, prioritize some kind of monitoring activity? ME2 now requires hospital leaders to set priorities with the international patient safety goals. So you all are familiar, I think, most of you, with IPSG or the patient safety goals, right? So now we have 5, not 6. And some have found their way also into the PCI chapter, and they've been relocated, but they're all still there. Okay, so how will you monitor these IPSGs is one of the things that leadership will have to decide. Hospital leaders conduct a data-driven risk-focused assessment annually for diagnostic errors. So this is something new in the 8th edition. So how will you identify diagnostic errors? And it could be in radiology, pathology, microbiology, it could be in patient care. It could be in areas other than this also, but this is where they're most likely to occur. And how do you assess and see, have a risk-focused assessment of these areas to prevent and manage and then prevent diagnostic errors? ME4 says that hospital leaders will implement evidence-based interventions, okay, based on these errors. So that's what I was saying. So you find out the errors, you analyze them, and then how will you prevent them from happening in the future? It could be missed diagnosis, delayed diagnoses. It could be wrong diagnoses, incorrect reports. There was a study done by the Society to Improve Diagnosis in Medicine, and they said errors became 17% of preventable errors in patients. Like, a large number of errors can be prevented. So the diagnostic errors, analyze them and see how you can prevent them from happening in the future. Okay. And okay, so this is the last slide for this GLD, and then after this we'll break for a 15-minute break. We talked about workplace violence, so it finds its way now in the measurable elements under GLD 0702, and requires that it is led by a designated individual. So we want somebody to own that program, and it is developed by an interdisciplinary team. We need written policies and procedures for this program and how to respond to these situations. How is this incident going to be reported? So many of the accredited organizations already will or should have a robust incident reporting system, right? Those of you who are new to this will be required to have, there has to be a system of reporting. Otherwise, in my hospital 20 years ago, something happened, and some way that information would reach me and the team, and then we'd wonder what to do with it and say. And then what I started doing was, every quarter we used to, department-wise, there was a competition to report incidents, okay? So if you have something like that, don't be scared. It's good to have all kinds of incidents. Whether you feel it's an incident or not, report it. So my caveat was, if anything happens that affects patient care, you must report it. It could be a sick staff member, report it. Because if you're sick, you're not supposed to come into work. So we used to have a competition, and that is how we started getting incident reporting. So department wise, it would be pushed that this quarter, this department had the maximum incident reports. I didn't reward them for it, but we encouraged the reporting, and that's how you will get to know of the incidents. So I used to get calls that, ma'am, this has happened, do I report it or not? So the caveat was, when in doubt, report. Because if you have no doubt, you're going to report it anyway. And if you're in doubt, we don't know, we might miss it, right? So I said, if in doubt, please report. Leave it to us to decide whether it was an incident or not. Okay. So what is your process to get incidents reported? What is the process for follow-up and support to the victims or the staff who were affected by this or any other incident? And what is the process of reporting it to the governance? So the governing body should also receive reports on not only workplace violence, on incident reports also in the organization, right? So we are close to our break. I think it's time to have a bit of whatever, tea, coffee, bathroom break. And we'll come back and continue with the rest of the session.
Thank you, Dr. Shaw. So refreshments are arranged outside the auditorium. We have it near the lift lobby. We also have refreshments arranged just behind the hall. So the ones who are seated on the front rows can use the ones which are there in the lift lobby. Also related to restroom, we have the restroom just behind the hall. So request all of you to please assemble back at 11:15. Thank you.
We can all settle in now to start with the next session. We'll be breaking for a lunch break at 12:45. Yeah. Just give me a moment. Okay, welcome back from the extended break. Guess we all needed it. And it's going to be like this till 4 o'clock, okay? Information heavy, but I will try to make it as palatable as possible. Feel free to reach out during the lunch break for any questions that you might have. Voila. Okay, we're back online. So we go into the next chapter, which is on staff qualifications and education. And I'll briefly go through, like the other chapters, on the changes that have come about in the 8th edition. Okay, so SQE 010.01 on staff responsibilities. So this is slightly different. It's a new requirement. You may think it's not new, but I'll just elaborate on it. So every staff member needs a job description. So that's easy, okay? So except medical staff, all staff members have a job description. So what do we mean by staff responsibility? So it's like there is a job description for a nurse. But then there are various categories of nursing: ICU nurse, ward nurse, operating room nurse. So the operating room nurse's responsibilities will differ from the one that is on the ward, right? So their job descriptions will differ. So they cannot be generic. So there can be a generic part, which is the JD for all nursing staff, and then their responsibilities are added on to that. So that is something that has been specified in ME2, that each job description includes defined responsibilities for the staff member of that job. So that's giving you a little more clarity into what responsibilities are. Likewise, it could be for all other departments also. And it goes without saying that medical staff, if they are performing a managerial role, then they need a job description. So that was there in the earlier standards also, but I'm just clarifying it for now. So say I'm a pathologist, but I'm also serving as the medical director of the hospital. So then my job as a pathologist is not defined, because that comes with clinical privileges. But my job as medical director will be defined in my personal record, right? So that's the difference, okay? So there are two things here. The medical staff with managerial roles need a JD, and all other staff members need a job description along with their responsibilities, which could vary. So ME3 talks about this managerial part of medical staff, and this was earlier in the intent of the standard. So one would think that, oh, it's in the intent, it's not in the measurable element. So this is one of the changes that has happened. So requirements were there earlier also, but we have moved it to the measurable element to ensure full compliance with that standard, right? So if medical staff has responsibilities where they don't practice independently, or they are educating, they are teaching, or they are permitted to temporarily provide certain services, then they have to come into their job description. SQE 01.03 deals with staff evaluation. So there is a process in place for staff evaluation. All staff have to be evaluated based on their job description and responsibilities. So there is evaluation, there is competency assessment. And again, this responsibility part that was added on earlier, that also has to find its way into the evaluation and competency. So ME2 is the hospital evaluates staff based on performance expectations that reflect their job responsibilities. So get used to these words, okay? The job description with specific responsibilities. Is it clear? JD and responsibility, okay? So there are two aspects to the job description now. So one can't go to a hospital, there are 100 nurses and they all have the same job description. It can't be. There'll be some here, some there. Some will be with that basic job description, but others will have responsibilities based on that. Now if the nurse moves from OR to ICU to where emergency room, then the responsibility changes or gets adds on to it. Say she's trained for ICU but not worked in the ICU, worked in the ER. Then if you put her back in the ICU, you please do competency assessment for ICU requirements, which will not be the same as in the emergency department, right? Some things may overlap, but some things are more specific. So if you change staff, then ensure that their responsibilities, competency assessment, evaluation also changes. Otherwise, you'll be evaluating as per the former role, but the person is doing something else and has not been evaluated. So we look for those. So during the survey process, how do we look for staff qualifications and education? So basically, if I'm doing a tracer in the emergency room and emergency department, and I end up talking to a nurse over there, it could be on Monday, Tuesday, Wednesday, which day of the survey, we don't know. She may be on duty, she may not be on duty. So we will pick out that name and give it to your HR person that I want to see this nurse's file tomorrow in the SQE session. So there is no saying which staff member will be, which staff file will be surveyed during the actual survey process. So that's how we ensure that it could be a random sampling across the whole hospital, right? The files. So every file has to have everything related. Now, if I open her file and see that her job description does not include emergency room responsibility, so that's a not met, okay? It includes the responsibility, but the nurse has been working for 2 years, not been assessed for her competency. It's a not met. Huh? So now, if I view 30 files and I find one not met, in one file which is in a ward, it's not as critical as finding that one OR nurse who has not been assessed. You see the difference? So the criticality and the impact that the survey has on the organization is assessed. So someone may say ki, oh, in that hospital survey, one nurse ka file was not correct, but they got accreditation. And someone will say, in my hospital, you know, this one file was not proper and my standard was not denied accreditation. Well, what impact that finding had on that hospital? Okay, what was the sample size? What was the reason? So we should not we should look at our own hospital and see whether that is fine or not. It's good to learn, I'm not saying that, but this is a tendency we have, you know. So wherever I went, I stood in the Middle East and all, and very competitive environment, and then they would say, oh, this place got this, and this place was asked this, and this place. Every hospital, even though you belong to the same head, you know, like Kaveri Hospital has so many branches, so many cities. No two hospitals are exactly the same. The policy, mission, vision, culture will be the same, but patient population is different, specialties may be different. So each hospital should be looked upon as a unique individual by itself, right? Staff are evaluated before or at the time that they start their responsibilities. So now you see the difference between responsibility and job description, okay? So if you're shifting a nurse, efficient nurse from the ward, you're training her for endoscopy, say. Then you train her for endoscopy, see her competency, and then allow her to work independently there. That's just an example. And the individual that will evaluate should be from that department or from that expertise. Now, you can't have somebody with some other, background evaluating endoscopy when they have no knowledge of what is required in endoscopy. So we will also look for the person who is conducting this evaluation. This was there in the earlier standards also. The other change is that, this is what I was saying, the ME5. An individual with the educational background, experience, knowledge related to the skills being reviewed. If he's not independently conducting it, he's co-leading that. He's somehow involved. So somebody has to be involved with that expertise to be able to evaluate if someone is performing well. Now you may say, oh, that's but logical. Sometimes it's not. You have just sheets of paper done, anybody is evaluating, yes, and then when you go and evaluate the nurse, say I interviewed a nurse and I didn't find her competent enough to answer something. We are not assessing clinical knowledge like that, we are assessing the processes, and then you go to the file and say, oh, but she was found competent. But then who did the competency test? Somebody who wasn't qualified. So a qualified individual needs to be involved in the staff evaluation. And these are done at least annually, if not more frequently. That is up to the hospital. Definitely, if you change the job description or responsibility, then you should be evaluating at that time, even though 1 year is not up. That's about staff evaluation. Now we go to hospital staffing. So there is a new ME that says it is complies with local laws and regulations. Now you may say there is no local law and regulation. All right, you comply with the other MEs. Because these international standards are not only for India, they are for all areas outside of the United States of America. So some countries may be having, some are not. So we want you to find out if there is a local law. So that prompts us to look, is there a law that governs me? In India, compliance is a big issue. Suddenly there'll be some person who will come and say, you're not compliant with this. And you never knew only that there was a law about it. So these kind of standards prompt us to look, is there a law for staffing in hospitals? Am I compliant with it? Right? So they have labor laws and minimum wages laws. There's so many laws in our country that we need to comply with. So see if there is a local law, local or national, and whether you comply with it. The other MEs are from the previous standard, but for those who, sorry, there's a typo on this slide. I'll just have to remove that, the process. This hospital staffing is monitored and it's coordinated with hospital leaders. Do you have adequate staff to provide the service that your hospital wishes to provide, right, to your patients? So you should be adequately staffed for the same. Staff orientation. So this completion, this is a new ME5 in this 1.06, which says the orientation is completed and a description is of these objectives is documented in the record. So earlier it may have been unclear, but staff orientation must be documented. Now you may say orientation to what? Orientation to your hospital, there's a general orientation, then there's an orientation to the area that you will work in, there's an orientation to the specific job that you will be required to do. And it will be surprising that we presume that people know. They will learn, they will be there, but it really helps if you actually give this orientation in the spirit of it. It just makes not only this new staff member familiar and comfortable, it also ensures that what you want them to know, they actually know. Many times we find new staff coming in, they don't know where the pantry is, they don't know where the lunch break is, they don't know anything. Give them an orientation so that and the more comfortable they are, the quicker they will settle into work at your hospital, right? Even there are staff that come from outside on a regular basis. Orient them to the hospital, orient them to the safety, security issues. Find out what you want, what is the minimum that these students, trainees, workers should know about the hospital, and document it in their records, okay? Even volunteers. You may say that, oh, he's a volunteer, and it doesn't belong to on my payroll. But they need to know they are going to be sitting here for whatever, 4 hours, 5 hours a day, or the whole day, social service person, whoever it may be. They all need to be oriented to the hospital and the services that are provided. Because if you know patients, they will ask anybody for a question. Like they will ask my security chap, you know, wo आँख का operation के बाद कितना घंटा रहना पड़ेगा? अरे, he will answer something. They tend to ask anybody anything, okay? So you have to train your staff what information not to give also. Because otherwise everybody is doling out information as they seem fit, you know. So orient staff, preempt, you will know the kind of questions that are asked by patients. You know, if you ask your staff members, they will only tell you that this is the kind of things we should know, or the patient always asks, so include it in the orientation, okay? So go with the spirit of that. This standard talks about staff education and training. So it was, this ME1 was created to better explain the expectations of ongoing education. So sometimes, or no, all the time, we are constantly learning, educating, training, but there's no record of it having been done. So one has to document it in the personal record that this education or training was given. Now all of you are working in an accredited hospital. Maybe you are accredited at the 7th edition. You will get a certificate of attendance at the end of this. That's your ongoing education and training, that you went and attended something for the 8th edition. So it's documented into your file. Anything that you take a copy and give it to your HR department to file. Normally, I find the HR department running after everyone. Arey, you all went to this conference, give me the certificate, give me the certificate. Arey, you give na, so that you go and give the certificate to them na, so that your file becomes robust. Tomorrow you are more organized, you know, with your competency. Tomorrow, if you want to ask, say you went for training for infection control and you want to be on the infection control team. If you give, then you stand a chance of getting onto that team na, until they figure out kisne training kiya tha, where to get that person from, etc. So voluntarily give and file it in your patient record. And during the survey process, questions will be asked to staff that, okay, now I am in the operating room. They say, okay, when did you get trained to be an operating room nurse or an operating room attendant? Who trained you? When was it given? Was there a time frame before you were allowed to work in? These are the questions that we ask, seeing the staff file. Then seeing the staff file is just an additional thing to know. Now in that staff file, if I find all the training, but the guy, he never answered only that he was trained. So in the consulting, when we go, suddenly they're all talking to each other. Arey, but you were trained. He said, I was not trained. You know, so it's fun to watch that, and you should do it in your hospital to see who is trained when, for what. And so this completion of training should be documented in the patient record. So in the survey process, it's very easy to know compliance with these standards. It's don't think we have it in our head, all these 700-800 standards and measurable elements. It's something I was telling somebody in the break that we had the tea break, and I said, JCI follows something called a tracer methodology to evaluate, and you trace the patient's journey through the hospital, right from the minute he walks into the front door till he exits. If you're working in the hospital, you can follow his whole route through all the departments, indoor patient, discharge, did he get discharge summary, did he sign his consent forms, who gave him the consent. It goes on. If you know just follow your policy and see whether, forget about the standard. If the hospital has a policy, just see whether that policy is being followed or not, or the procedure is being followed or not. That's it. It will be tied into the standard somewhere or the other. But that's the best way to see whether your processes are working efficiently or not. Yeah. So, sorry to digress, but this is what is on staff training, competency, and the documentation in the record. So this is a new standard that has been introduced on staff mental health. As all of you know that anxiety, depression, things are increasing, or they were always there and we didn't know about it. So we don't know whether it's increased or whether the awareness has increased. But the new 8th edition is looking at staff mental health as a part of staff welfare. Okay. So common stressors that happen in the place of work could be no support from management, or the work suddenly has increased. You know, I was employed to handle 10 patients an hour. Now suddenly I'm handling 15. So that's the pressure on me. Staff is short-staffed in certain departments. Sometimes you're working long hours, you know. Patients die out of whatever reason. Sometimes you can handle the death, sometimes you can't. So, and of course, the violent situations that occur. So all these contribute to underlying stress on staff members. And there is a staff health and safety program that was there earlier also, but mental health has been included into that, right? So, some aspects of the health and safety program could be initial health screening on employment, exposure to blood spills or any toxic drugs or too much noise. You know, those machines in radiology have a lot of noise. So imagine if staff has to all the time hear it. So they are given, you know, protection for their ears. On patient handling, they are second victims of adverse events, or any other injury that may take place at the work. So all this can happen, and the staff health and safety program takes care of this, right? So mental health is now addressed in measurable element 3 of this standard, and there is a process of follow-up and support. Staff need to know that if you identify the mental health issues and or any other issues, and train them to reach out to whom in that situation. Sometimes staff doesn't know. Like when there was some kind of a flu going on, you know, most healthcare staff, at least I believe, are very dedicated to their work. So they will show up no matter what. Sometimes I have to tell my OR nurse to please take leave for one day. There is no OT list today. Why do we have paid leave? To take. But everyone's so dedicated, they come often, they don't realize the stress they are going. So they need to know whom to reach out if they have 1, 2, 3, 4, 5. Nobody is going to say, I am stressed. But identify those stressors and educate them that if you have this, don't. So like I had to tell my staff that when there was a flu outbreak, please don't come if you are having a coughing, runny nose, especially if you are in a patient care area. You will just transmit that to the people. The staff doesn't know that, oh, I had to inform that I have flu, unless we told them to, right? So identify the stressors and the harm that could happen, and teach or orient staff how to reach out and whom to reach out to if you have a situation like that, right? So, yeah, so ME5 at a minimum says look out for burnout, look out for fatigue, look out for self-harm or suicidal ideation. It's very difficult to detect these things, but there are various criteria given, and staff can be told, if you feel like this, reach out to so-and-so. That's it. It's all confidential. It is all not shared with anyone. They should feel free to reach out, and therefore we can prevent, you know, mishaps happening. Sorry. SQE 2.01 deals with staff immunization. This was there earlier, but ME3 now defines that there is a vaccination and immunization program which is as a hospital policy and a process for administrating and management. So I don't know if you already do it or you don't, but there are certain like patients in the lab, staff in the lab and in the OR who are exposed to bodily fluids. Especially in the lab, at least in the OR, you know if there's an infectious disease because the person has been investigated. But for lab staff, we're dealing with samples that are coming for testing, right? So in laboratories, we tell our staff that treat every sample as potentially infectious. We don't know. Till the test results come out, you don't know whether it's a hepatitis B or a hepatitis C positive, right? So after you know, you've already handled the samples, you're already exposed to it. So there's something called a universal precaution that every sample in the lab is treated as potentially infectious unless proven otherwise, right? So determine which staff needs what kind of evaluation and vaccination accordingly. So that is the immunization program that should be well defined and followed, and we will look for evidence of it in the personal record, right? So as a baseline, one hospital just did Hep B antibodies. So if your antibody level was high, then you didn't need a vaccine for hepatitis B. Those who had an antibody level that was low all underwent that 1 or 6, I think there are 2 or 3 doses for Hep B. It keeps changing, so keep informed about what vaccination should be given to staff in the hospital, and then how are you going to give it, monitor it, and document it in the record. Okay. Okay. So workplace violence, again, it's in staff qualification and education also. Staff needs to hospital needs to provide training, education, resources at higher or annually regarding the workplace violence prevention program. You need to determine what kind of training you have to give to which individuals in their role and responsibility. Identify, you don't have to train the entire hospital on it. Identify maybe leaders, maybe, I don't know, see the previous incidents and decide who should be trained, what kind of training is given, and where you are going to document that training, and define what constitutes also workplace violence, and educate 3 to guide you or to give you a direction on what kind of education to give to the staff, right? So such kind of, to see compliance with this standard is usually due to conversations the surveyors will have with the staff members. Now if the staff member says, what is workplace violence? Then obviously the hospital has not trained. There is no need. I will still not go into details. If 2-3 people answer me, what is workplace violence? I don't know anything about it. So then clearly this ME is a not met. I'm not going to go and ask the hospital, did you do this? Did you not do this? Look for, and I will look at the staff file. There is no evidence of it. Means it's not done. So we don't spend time drilling down unless we find a gray area that someone is answering, someone is not. If it's clear cut, there is no need to waste time on that standard. So you will suddenly find it in your report that, oh, this has come in the report, you know, that there was no chance for you to prove otherwise. You said, then you may say, no, I have a plan for training for workplace violence. That doesn't work anymore. You have to show evidence of in initial or triennial survey of it having been implemented from the day the standard became relevant. So if you're going in for 8th edition this year, from 1st Jan 2025, it should have been implemented because these standards came into play then. So having a plan and not implementing it also comes as a not met. Right? It's great you have a plan, but you've not implemented it. So it will not be a met in the... Earlier, there used to be a gray area, partial met, at least there's a plan. They plan to do something, show us that you're going to do it, but not anymore. Okay? Going on to nursing staff credentials. Okay, this is SQE 3.01. So ME1 has, it's not that it wasn't there earlier, but it has expanded and made the expectation a little clearer. It says nursing staff has the education, the experience, training, certification, which is consistent with what the hospitals provide services and is tied up with their job description and job responsibilities. So it all needs to match. I may have certification or training in some specialized nursing area, but that service is not provided only in this hospital. It is of no meaning. It has to match. He or she has to be trained and competent for a service that is offered by this hospital and where they work in. And we need to see their current license and their current competency. Means what are they competent for at this point? And their licensure should be current and updated. Most medical councils or nursing councils have a 3-year period for which it's valid, or sometimes it's 5, depending on the state that you're working in. Also ensure that if the staff is coming trained in another state, they need to be re-licensed in the state where they are working in. So that license will not work in this state unless that state says that we accept licensing from another place. So be very diligent about all this. I used to really, we have this source verification in JCI, and in our first survey, I thought, what's the point? Obviously, these people have all gone to college and earned and come. And there was one nurse who did not pass competency. 6 months had passed, not competent only, certificate, everything there. So I was wondering, so then the source verification came in, and half the time in India, at least 15 years ago, there was no reply. So no reply means what to do? Now I have the nurse, I have to keep her. This particular institute replied. To our shock and disbelief, she had not completed the course. She had just given the provisional certificate, fudged it a bit, because she's not passing the competency only. So it helps you identify that one person who is really not competent, and God forbid she is in a critical area of care in your hospital, is not going to be able to optimally provide that service. So on that day, my entire staff agreed that source verification has to be done, madam. I said, yes, it has to be done, no matter how senior or junior the staff is. So that really taught us that things do exist, which are fake certificates. It may not be common, but it happens. So be very diligent about their license and regulations. Okay. Yeah. Going on to medical staff clinical privileges. So, some of you are physicians in the room or are not, but medical staff is not evaluated for a job description like other people are, because they have been trained through MBBS, through MDs, through whatever, to be able to give that service. The way we assess medical staff is by delineating clinical privileges. So, are you all clear with it, or should I expand a bit on clinical privileges? expertise. Yeah. So if you're clear with privileges, I won't get into that. So a medical staff is required to request the hospital that I want to perform these procedures in your hospital, and then the department head will say okay, or under supervision, or not okay. Okay, so that's how the privileging process goes. And so this part of that privileging process was in the intent of the standard, so it has been moved to the measurable element, because we found that some people are compliant and some are not, just because it did not belong in the measurable element. So now that requirement has gone into the measurable element, so you have to comply with it. The change that has happened is in ME2, that there are criteria. The hospital has to establish certain criteria that determine the ability to provide that patient care and treatment, which matches with the privileges. It should include all these following: that a current license or certification verified with primary source. Relevant training also has to be verified from primary source. So it's one thing to verify the degree, but say that surgeon wants to provide plastic surgery of burns patients, say, and that's a very, very specific, not every plastic surgeon does that according to my knowledge. So has he been trained for that particular grafting or skin grafting, if it's a very specialized? So even that training has to be verified from primary source. So that has become very specific now. Physical ability to perform the privilege. If he or she had trained somewhere else and data is available that privileges the applicant, that is acceptable. All these points were not there in the 7th edition. If there is a peer or faculty recommendation, and when reviewing the privilege, the review of the performance within the hospital of that particular doctor. So these elements have been greatly detailed into measurable element 2 of the standard. And continuing from there, there is a section that deals with temporary privileges. This was not there in the 7th edition. Okay, so there are certain reasons for giving a temporary privilege. Maybe a particular kind of patient care treatment or service, or when something a new privilege has been requested for, that there's some new procedure, like sometimes it's shunts or there are implants or something that they want to do and they've trained, and you're waiting up source verification and other approvals happen. This I think it'll come in the next slide. This temporary privilege is valid for not more than 120 days. This is something new that has come up. It'll come up in the next slide, I think. So these are ME3 tells you in which conditions the temporary privilege may be given to the medical staff. Okay, it's just a list. It's there in the standards. You can read it. But it's usually pending approval that this temporary privilege is given as per hospital policy, of course, and they are on the recommendation of usually the medical director or the head of department. And this is what I was saying. ME6 says that the temporary privilege are granted for a maximum of 120 days. So then it is withdrawn, okay, if not approved within that time frame. Reappointment of medical staff. So medical staff also undergo a performance evaluation. There are 2 new MEs in which has been elaborated in the standard. Medical staff members and other staff requesting privileges are notified regarding the granting decision. So say I request for a privilege for, I don't know what example to give, a new kind of surgical intervention based on what is happening so far. There's something new that has come in. I've got trained for it. And I'm asking for the privilege for me to be able to perform it in this hospital. So when I am granted or not granted, you have to document and inform that medical staff member. It cannot be a verbal or an email or something. It has to be properly documented that this privilege is indeed granted. And ME5 says that there is a system to all these granting, modification, restriction decisions are available to whoever needs to know. So usually it happens in surgeons that they are given a privilege, and then the OR is informed that this surgeon has the privilege to perform this specialized procedure or not. The thing is to prevent untrained medical staff doing procedures that they are not allowed to do. So that is the whole idea of this privilege delineation process. And that privilege, granted or not, has to go into his or her personal record, the staff file that is maintained. So this entire process, and then reappointment of the staff is usually we tell to review the medical staff file at the end of 3 years. So each time the performance evaluation and this clinical privilege delineation process is followed as per the policy. How do you assess that the medical staff is indeed capable or is performing well? So ME4 says data can be collected from hospital-wide or department service in ongoing evaluations. That data that you collect regarding a particular medical staff member, you should be able to identify. For example, you want to know the performance evaluation of the physician or internal medicine doctor in the ward. You will have data to know what he is privileged to do, what are the outcomes of those privileges, and based on that you will reappoint the doctor. I normally take this session whenever I go in hospital, and we are a room full of doctors sitting with the HR file, and everyone says, why do we need to do this? It is not to doubt the integrity of a medical staff member, but it is explained to them from a patient care point of view. And there may be one who needs more training, So it's just a method to ensure that there is no patient harm. It's not, medical staff should not look at it as if you're doubting whether I can do my job well or not. It's not about that. It is just ensuring optimal patient care and patient safety. And that is where we have to approach this delicate topic from. Okay. So, yeah, and it also, this data collection should be according to the clinical practice of that individual staff member. You can't be evaluating him for something he doesn't do. So, I mean, it sounds very redundant, but you have to match that data to that doctor for the service that he provides. Now, if you see the intent of this standard, this is a very, very brief overview. One slide cannot cover the detail in which medical staff is evaluated. So if you look at the standards manual, it's very, very well detailed on how to collect data, which data to collect, and how to evaluate. And it is a one-time process to set the policy and process in place. Once it's set in place, it will just go year on year automatically. It's not difficult to do. And yes, it is always department-wise. So the evaluation for a cardiologist cannot be the same as the neurosurgeon, cannot be the same as the transplant surgeon, cannot be the same as the cardiac surgeon, transplant surgeons, and all So they're all different, okay, those different headers. So according to the scope of services your hospital provides, plan out the staff evaluation according to the scope of services that you give. So no point looking for a scope of service that you don't give only, and then you have this whole detailed material. I've gone to hospitals like that also. They'll have evaluations. I say, but you don't do neurosurgery in your hospital. Yeah, but we just made it. No, that means it's taken from somewhere else. So please keep your documents, your policies, procedures tailor-made to your hospital. It's nice to receive ready-made policies and procedures, and many times you don't read it, and then when we start to read it, we say, but this is not done here. So why is it here? Then you realize it has been begged, borrowed, stolen from somewhere else because you wanted to save the trouble. So please don't fall for that. Never mind if you delay your accreditation for 6 months. But please see that your policies and procedures are relevant to your hospital and yours alone, not taken. You may take a structure from somewhere, but then it needs to match what you are doing in your hospital. And this goes for everything, not only for medical staff evaluation, for everything. Please see that your policies, procedures belong to your hospital. It doesn't end. SQE. Medical staff, my God, all of you who are not medical staff will say, "Arey, ye kya hai?" Anyway, there's something called focused professional practice evaluation. So, if you do not have that clinical privilege, so don't worry. If you don't have it, who does not have documented evidence, this is that competency for that focused area, okay? So there may be that a person is trained but has not got official training, okay? So, but he is still able to perform that service. So this is where that comes in. A focused evaluation can be done if those initial training is not available or is pending. And this is just to ensure provision of safe and high quality patient care, okay? There are several MEs about it. It's clearly defined. Criteria, the method for determining the performance monitoring, the circumstances in which someone else can monitor the medical staff. And if there are any issues regarding performance of a particular medical staff, then these measures that are employed to resolve these issues are defined in writing and implemented. So this basically concludes staff qualification and education. And if you have any specific questions that you want to ask, or I will start the next half of the training. We can start with that, because that's also another long slides. Anyone needs a break? Anyone needs a question? Okay, fine. So, because I said you will see a thank you and then see a lunch slide, which is not happening. It's not the end of it.
I would like to have information related to infection control policies.
Coming. Okay. What's happened to this? Give me a minute, I'm just changing the presentation. Can you help somebody? I just need to. It's frozen. See this? Maybe I do Control Alt Delete. Yes, please. Shall we give you a mic? Can you just give her a mic?
I just want to know whether when you say medical staff, you mean doctors, and clinical staff, you mean paramedical staff?
No, by medical staff, it's only doctors.
And clinical staff?
Clinical staff are other clinical
That's what?
staff.
Paramedical.
Paramedical, but that's not medical staff.
That's what?
Yeah, yeah.
Medical staff or doctors?
So we have
and the rest
medical,
are clinical.
we have nursing, and then we have the rest. Or rest of medical.
So nursing will come under clinical staff.
No, nursing will come under nursing. We have a separate section on medical staff, then we have a separate section on nursing staff, and then we have a third section on other professional staff. Other staff that provide patient care, like physiotherapists, lab technicians, radiology technicians. So they all come under pharmacy assistants.
Paramedicals.
Yeah, they all come under paramedical. So medical, nursing, and others.
So privileging for them is also...
Privileging is only for doctors, not for nursing and other paramedical staff. Because doctors don't have a job description. They will only have a privileging system. Yes.
The dietetics, pharmacist, ICF, I mean, all the
They are
we just do the credentialing, training, competency mapping. That's it.
Yes, yes. That's as per the 7th edition. There's current licensing, there is training and competency assessment, and then re-evaluation every year. And ongoing training, ongoing education.
So the privileging doesn't come for...
Privileging is only for medical staff. Yes.
Not for nursing staff.
Not for nursing, no. Nursing will be job description and job responsibility, which is...
And competency.
And competency. Competency is for all. There was someone in the back who had one. Can you take a mic? Can you pass? Yes.
A doctor is trained on new technology. He want to start practicing in the hospital. How he will get evaluated? Because
Yes.
The medical head doesn't have this technology.
Yeah. So it's. Can you give an example?
The Da Vinci D5, it is going to come
Right.
next
So
year.
he would have received training for it.
Yeah, the doctors
Right.
got the training.
Yeah, so he will provide that training, this thing to you, that I have been trained to use the Da Vinci. And if your hospital has the Da Vinci, so he can use it under that focused FPPE, that temporary privileges. And then that's a maximum of 120 days. And if you have no reason to, you can also look for an external source. Like people who use the Da Vinci are few in number. And if there is an expert in the field, your hospital can definitely reach out and say that, can you oversee one? It's a remote thing, right? So they can oversee the technique and prove competency also.
Thank you.
Yeah. One has to look for solutions to ensure. See, ultimately, just keep patient safety at the top of your head. It's not about displeasing a doctor, or just from the patient safety point of view. When the intent is clear, everything is fine.
Thank you, doctor.
Yeah. And for medical staff, you can always use JCI as an excuse. Sorry, I didn't say that. Yes, sir. So if you want, I am not aware of NABH standards in detail, but if NABH wants for nursing and you want NABH, then you have to comply with it. Give him the mic, na, so others can hear. Yes, sir. Please take.
Ma'am, you are telling that medical doctors require the privileges, but maybe I wrong also. But
No, you are right.
NABH said that nursing first
Also
cross-check credential and followed by according to the credential and experience,
Right.
provide the privileges, ma'am.
Right.
So always, because I many times faces the NABH, they demand papers and documentation, ma'am.
Yeah, so if your hospital wants NABH accreditation along with, so even JCI is asking you to get current licensing and regulation for nurses also. I've just not put it up on the slide because there's no change in the process. Our session today is to overview to those requirements that have changed or been added on. So we also require nursing licensing and training. But if NABH wants privileging for nurses, and if your hospital wants NABH accreditation, then you'll have to comply with it.
Because many times they're like in Kaveri, they bought JCI and NABH.
So then you have to comply with both. There are hospitals abroad that have 5, 6 accreditation. They comply with all because they want those logos on their thing. So it's a free world.
Thank you.
Yeah. Yes, sir.
Ma'am, a nurse posted in a ICU, done BSc nursing only, and whatever the training she has got within the hospital.
Correct.
As per JCS standard, can she work in that institution?
Yes, she can. You have to show evidence of the training and you have to show evidence of competency.
Okay.
And it will be accepted.
Because one of the audits, they said within house, the certification will not do.
So you
they need
have
to have a critical care training has to be given.
Yeah, so then she also needs ACLS, no? So that will be your critical care training.
Correct.
Right? That will come under critical care. You have to prove also that specialized training not available anywhere else, and therefore it has been in-house trained by so and so. If there is training available, like in Bombay, we have this, just to give an example, we have this association, it's called the AMC, Association of Medical Consultants. So what they do from time to time, because these small hospitals and all don't have trained staff like this, so time to time they conduct trainings. So very often I have sent my staff, the nurses for hazmat training, for infection control training, and they get a certificate, they come, and then we assess their competency in understanding. So it would be a good idea to provide that, put it into that ongoing education and training. And JCI is quite sensitive to cultural differences that occur from region to region and country to country. So you should be able to prove that you could not find training or anyone better than this person, and therefore you have in-house trained and found to be competent, and they can work.
The element of bias can be removed like that.
Yes. Now, see, for me to give an opinion in this forum, it may or may not be valid because I don't know your hospital. I don't know the scenario in which this occurred. But I had come across certain situations where, the key idea is to prove the intent and the spirit with which you want to comply. You're not doing it just because you want a tick mark on that standard. You're doing it, you are aware that the ICU nurse needs to be trained, needs to be competent. You're not been able, she has been working for 15 years, she has enough experience, and therefore she is an ICU nurse. Now, whenever there's an opportunity for ongoing training, give it to her. Prove.
Actually, this was a question from JCI assessor only.
Okay.
He said...
now he caught me from the other side.
That two nurses are there, both are BSc nursing. One is working in ICU and one is not working in ICU. How do you differentiate yourself?
Yeah.
That was the question, actually.
That was the question.
Then she said, I've been trained in my hospital. That is the only credential I have.
Yes. I would add on competency to that.
Correct.
Training is one thing. So I may train you today on JCI 8th edition standards, but are you competent to carry them out? Not yet.
Correct.
Because you really need to undergo some assessment. I don't have a test at the end of this, but I would need to give you all a sheet of re-evaluation and then only say that, oh, Mr. So-and-so is competent to be able to implement the standards in his hospital. So show good a competency of work in the true spirit, and it should be acceptable.
Thank you.
I hope I answered the question.
Yeah.
Please tell him, no? There is a course going on.
Like IDCCM, madam, IDCCN course is going on, Indian Diploma in Critical Care Nurse.
Yeah, so
Then, you can
find
take,
out these places and send your staff. No, it's
hospital-
good to come abreast with newer techniques also, you know.
Yes, yes.
The reason for attending trainings even after 15 years of working is not that I'm not competent or I'm not able to provide this service, but it is just to prove that I can, not prove, just to be able to learn something newer, because things are changing in today's world, you know. The way I did microbiology 35 years ago is not the way it's done today. So when I stopped doing microbiology practice, I really have no idea. It's great to attend these training sessions to know what's new, how much it is automated, how much the reports come out, you know, in that way. So ongoing education and training is part of our standards. So that should
Madam,
come
it
in.
is affiliated by Indian Critical Care Society.
Sorry?
It is affiliated by the Indian Critical
Critical Care,
And hospital can take help of a critical care specialist and demand the course.
Correct.
And by default, they train the staff. That
Right.
is this Weber.
Right. Good. Okay. 10 minutes to lunch. We will do a few slides and break for lunch. So this section will focus on international patient safety goals, assessment of. So we're going now a little more clinical compared to the managerial standards, right? So what I will discuss now is these chapters specific to 8th edition manual and the changes that have come into place in these standards. And like I said, difficult to go into every change that has come, but the high level changes that have happened, we will go through. So IPSG 2 deals with critical test results. So this is there, it was in the earlier standards also, that the hospital defines in writing for which the critical test result will impact patient care. So most labs, most hospitals have a list that when it goes beyond a certain value or below a certain value, one will call it a critical test result, and hospitals will have a policy or process in place to inform the physician, because it's life-threatening, very high blood glucose level, a very low hemoglobin level, and unless we analyze, we don't know, and that could impact patient care. So there's a process in place to inform these. Now, there is a formal process that needs to be in place to know how will this critical test result be reported or communicated to the physician. Like little change in language and the expected time frame in which you will give it. Now this was not specified in the 7th edition, so it used to vary. Someone said, oh, it doesn't say how soon, it says immediate. What is immediate? Who is it given to? I informed the nurse. Nurse did not inform the doctor. Lot of loopholes in it. So we have said the expected time frame in which this critical test result will reach the physician, and what is the process for it, and that has to be documented into the patient record. And now this little red line, the hospital monitors compliance with this defined time frame. So if I say that within 5 minutes the physician has to be notified of this critical test result, then I want to look for evidence of it being informed within those 5 minutes. Now you'll say how? The time of entry into the record is usually what we would consider as having reached the, it could be before also, which is fine, as long as it's within that defined time frame, right? this time of entry into the record may differ from the actual information, but I would safely expect that the time of entry will be after the doctor is indeed informed. So let's go with the spirit of understanding that. So it's not about how fast I did it. It's about that it got informed in time, patient care was going to be impacted, patient care was saved, and in the spirit of it, it is actually documented in the record. So it's not a race to find out what it is. Let's go with the spirit of that documentation. Sorry, 1 minute. Oh yeah. IPSG 3 is dealing with high alert medications. This is something that has come along from various hospital standard editions. High alert medications are to be first identified, that in your hospital, which are the high alert medications that you have. And then a risk mitigation strategy, by which we mean is, what is the best way that you will see that this is not inadvertently admitted to a patient when not required, okay? So reduce the risk of harms and tailored strategies. So there's a specific way in which you will manage high alert medications in your hospital. And annually, you will see this list and revise it. You may add things, you may remove things from that list. That is based on the hospital. What are the ways in which you can implement it? You must be able to explain why this particular drug is on your list of high alert medication, and what is the strategy that you have to keep it in place. These are just examples on how you would separate those drugs the way you want. It is not a prescriptive way of doing it. Like they said, neuromuscular blockade medication is segregated from others. It is with a lidded container. It has a warning label on it. How you want to manage that high alert medication is entirely up to you. These are just examples that we are giving as a part of this discussion. Need to be segregated. What goes on that list is you decide. How you want to manage them, you decide. Okay, but we want to know that you are compliant with management of high alert medications. Usually there's a list of medicines that are found to have, the percentage of the drug is so concentrated, like concentrated electrolytes are high alert medications. And then it's 50%, sometimes read as 5%, and it is inadvertently a high dose is given to a patient. Those are the kind of incidents that happened in the past due to voluntary reporting from organizations all over the world and in the United States. And therefore, they came up with this list of high alert something to caution you before you use that medication, just to be doubly sure that it is not inadvertently used. Okay, so that's the spirit of this standard. Right, so 3.02 talks about concentrated electrolytes specifically. And these are the strategies that can be taken to segregate this. And this, it's like you have the safe medication practice, then you remove it from storage locations. If they are outside the pharmacy, where will they be stored? Not in all areas of the hospital. And so ME2 does allow you to store them outside the pharmacy, but in designated areas only. And then ME3 is a new requirement of a proactive risk assessment. So at least annually, you have to revisit this policy of concentrated electrolytes and see whether that needs to be managed or needs to be modified. Your process needs to be modified. For all locations, Yeah, that's about concentrated electrolytes. So the only addition is the proactive risk assessment that is required to be done at least annually for concentrated electrolytes. Oh, we are at lunch. So we'll stop for here now. There is one more IPSG. I didn't finish the IPSG because that has a new requirement, the site marking and timeout and all. So we'll discuss it in detail post lunch. Thank you for your attention. I'm there through lunch for questions if you may have any. Yeah.
Thank you, Dr. Shroff. So we will now break for lunch. Lunch is arranged in the 6th floor dining area. Our team members will be there outside to guide you all to 6th floor. And we will all assemble back at 1:30. Thank you.
I'll just leave this as it is.
Okay, no problem.
Just look at the battery.
Slide.
டெவலப் பண்ணி எங்களுக்கு அது என்ட்ரி அந்த மாதிரி வாண்டட் டு ஸ்டே ஒர்க்கிங் ப்ரோட்டோடைப் அதுக்கப்புறம் தான் நான் நெக்ஸ்ட் ஸ்டெப் டு டெவலப் த
Good afternoon and welcome back. Sorry for the slight delay. So now my job is to keep you all awake after lunch. And it's only if you don't doze off that I will know that I'm successful. On the morning session, continuing with the IPSGs. Okay, so the IPSG for all good? So the IPSG for invasive procedure site marking was already there in the previous standards, but there's a little expansion on the requirements from even from WHO, which specifies in IPSG 4 ME1 there are certain items that have been added to the existing checklist. So one now needs to evaluate whether there is a risk of blood loss which is more than 500 ml or more than 7 ml per kg for children. This is a very, very prescriptive requirement. You will not see this very often in our standards because we tend not to be prescriptive. We tend to give that leeway, but now when we refer to certain international standards like WHO, and this is very prescriptive, so this is what you will have to include in your pre-op, the verification checklist. And also whether the patient has a difficult airway or aspiration risk. So this is part of the pre-anesthesia assessment, as one would definitely know, but now it is finding its way into the pre-op checklist, and also if there are any known allergies. So it's not that we did not consider difficult airways and allergies earlier, but now this is a part of every pre-operative checklist for invasive procedures. IPSG for ME3, requirement for an alternative process for site marking that is outlined in the policy. So this was there only in the intent statement earlier, but now it is in the measurable element. So when we need to specify when site marking is not possible, so in dental procedures, it's usually you don't mark the actual tooth, you mark it on the X-ray of the teeth, where it may cause tattooing in premature infants, so there's an exception to site marking there. And what happens when patients refuse site marking? That's a very not a very easy situation to handle, because you would want to mark the site. So I shared a little story at lunch with my colleagues, and I'd want to share it with you. Site marking, once you implement it, it's a part of the process. But I don't know about you, but in my hospital, there was great objection to site marking. We are an ambulatory eye care center, so we have to mark right eye or left eye. And nobody wanted to mark the site, not the nurses, not the doctors, not any paramedical staff. They all thought it is the worst thing that we can do for the patient. And I had so much resistance to it. Till one day I said, can you just mark the site for one patient and let's take it from there. And when so we had delegated that responsibility to the chief nurse, because that was allowed at that time. because the surgeon would already be scrubbed up and he could not come and mark the site before. So we had a double site marking. The nurse would mark it in the ward, and then the surgeon would recheck it at pre-op when the patient went up to the OR. And I can't tell you how relieved the patient was when we first marked the site, because he says, until now I was so nervous whether you're going to remember which eye to operate on, and now I'm at peace. And once the patient told that to the nurse and the doctor, I have never had a case where site marking did not happen. So very often we have this assumption in our mind that what kind of a standard is this and why should I do this, and it will, so when we say patient refuse site marking, I would encourage you not to give that option to the patient. Make it an exception, not the rule, to refuse site marking, because a large number of incidents that do happen, that adverse events that do, are often related to site marking. Being the wrong site being operated, the wrong level of vertebra being operated, the wrong tooth, or something, a large number of errors do occur due to that, and therefore this is a very important part. So while we tell you to have a process in place where the patient, what will you do if the patient refuses site marking, then that's fine to have an exception, but don't make it like a norm that, okay, I will follow this policy just because I don't want to mark the site, right? Talking about timeout. Timeout is a process that is done just before the surgical procedure is to start in the OR with the entire team scrubbed and ready to start. It does not happen anywhere else. Once the timeout occurs, nobody leaves the place when the procedure starts. So you have to find that time where you're going to perform that timeout, right? So the areas marked in red on the screen, it's not that they were not there earlier, but they have been moved from the intent statement into the ME. I told you in the beginning, certain requirements were moved because there was ambiguity. So the patient identity, the correct procedure, the correct invasive procedure site, the name of the procedure is written. Now, before the patient, so there is a timeout now. When the patient leaves also, the sign out is it called. It's not timeout. Timeout is in the beginning, sign out is at the end, which includes the name of the procedure that was done. So sometimes you start a procedure saying you're going to do this, but it may get modified if you are aware of it. It does happen when you see medical audits. There's a slight change to the procedure because of what was found during surgery. So even at sign out, you have to confirm what was the procedure carried out on the patient. You have to complete the instrument, sponge, needle count as applicable. If there is any specimen that was removed for investigations, it has to be labeled. If there were any equipment problems during the procedure, they need to be addressed. So these requirements have now come into the measurable elements, so they have to be done for each and every patient. Yes, please. It depends on what you are. Normal surgical consents usually say that this is the procedure planned for you, and you give consent for any change that might need to be done. Change, I mean, it's a minor change. It's not that you are operating on the kidney and then you're going to do something else. So if you're doing something completely else, you have to stop and take a consent if not taken. But normal consents usually do give that leeway for change, minor change in the procedure if required. So it's even in the anesthesia consent. You may go in saying you're going to do an epidural or a spinal, and then the usual consent forms have that caveat that should the patient have this condition, then a general anesthesia maybe, and the patient gives consent for it. So even in surgical consents, that is there. But if you're doing a second procedure, like a completely different thing, then you have to take another consent, right? See, there are always exceptions to the rule because every patient is not going to be the same. So again, I would say go with the spirit of doing things in the right intent to cause minimal patient harm. So if you are going to intervene and do something else, sometimes you do less. You open up and you say, exploratory laparotomy, I can't do anything, cancer spread, just sew it up and come back. What about that? So things happen, and one has to comply with the standard in the spirit of it. Yeah, so the ME4 is actually addressing that. When two or more separate procedures are performed on the same patient, another timeout will be initiated, and therefore you will have another consent. So this could be planned or it could be unplanned also. So sometimes they are planned, like the orthopedic surgeon comes and does something and then the heart procedure is done. This happens rarely, but it does happen because you do not want the patient to undergo anesthesia twice, right? Usually that's the logic, that while it may be due to comorbidities, you want to finish two procedures in one thing based on, so it's all case to case based. So if there are two separate procedures, you will have two separate timeouts and sign outs, right? IPSG 5 is focusing on the hand hygiene program. There are several guidelines, evidence-based guidelines for hand hygiene that are available. So ME3 is what is added on to this standard, which the hospital has to collect and analyze data for compliance with the hand hygiene or hand washing procedures. So whatever is implemented, there are various ways of measuring compliance with hand hygiene. And this, it was not that it was not there in the standards earlier, but it has been brought into measurable element 3 under IPSG 5 now. I think it used to be in PCI earlier, but this data collection or in the quality chapter, but here it has been specifically brought into this IPSG 5. So I think that concludes the minor changes that we have had in the IPSG standards. So we'll go on to the AOP, or assessment of patients chapter. I just, sorry to interrupt, but when did you want a break? Somebody, okay, Linde. They wanted a break in the afternoon because we have a long session, but you can just find out when you want it, then I'll start. Assessment of patients. So initial assessment, like I said, in this chapter, written requirements have been outlined. So there are few changes which is highlighted in red like the other slides. Many elements again were in the intent, now they are in the ME. We require you to specify who is responsible for the initial assessment and the timeliness of the initial assessment. It says initial nursing assessments are now completed within 8 hours. Earlier they said initial assessments, the time frame has to be defined by the hospital. And in each discipline, which part of the initial assessment, who is responsible for completing. You have to define the minimum content for the initial medical and nursing assessment and minimum content for other assessments. Other assessments means those other than the physical and nursing, like for physiotherapy, for dietitian, for social services, anything else. And what are the documentation requirements? What has to be documented into the record within a defined time frame? Also, we need to identify in writing those patient groups and populations that require modified assessments. So what do we mean by modified assessments? Modified assessments means infants, pediatric patients, elderly, terminally ill, patients with psychiatric disorders. These are just a few of them. These patients will not only require an initial physical and nursing, they will require something more detailed, specifically suited to their condition, obstetric patients. So one has to identify all the patient populations that you see which require this modified assessment in addition to the initial physical and nursing assessment, right? Sorry. Okay, going on to the next standard, which has some changes, is in the lab requirements. AOP 03.03 is reporting of lab results. So ME4 is specifying when laboratory results action taken. So we do expect reports to come in a defined time frame to us. So every lab defines that this is the hour. So if it goes beyond that time frame, then what corrective action? So what was the reason for it being outside? It could be a test result sent to another lab, breakdown in machinery, anything. And what are the corrective actions? Was it critical? Was it non-critical? Do you have backups for certain tests, etc.? So it goes into that discussion. So why that time frame was not met, and if there is a barrier that can be rectified, then what has the hospital done to rectify it? AOP 03.05 deals with reagents. So reagents reagents are the solutions used to conduct the tests in the lab. They undergo quality control testing as required. And the record for the reagent should include the following. What is this reagent? When was it prepared? Does it have a lot number? What is the expiration date? What is the date that it was put into use? So we have this, every time you open a reagent bottle which is used over multiple dosing, right? Multiple times, not dosing. Then there's an opening date or an expiry date on it. So to prompt the person using it that it will not be valid and you have to use it within this time, or then discard it and take a fresh batch of reagents. So we will look for evidence of that. AOP 4 is the blood bank and transfusion service. Again in ME2, this donor selection, screening, blood collection, storage was all in the intent, has been moved into the measurable element. ME5 is a new standard which requires the hospital to process, to monitor and improve blood product utilization. So what is the optimal use of blood products? What are the safe practices? Availability will come under this standard. So basically, just to make it simpler, is the blood being utilized optimally in your hospital? Maybe you can divide it into various blood products and use. So one blood bag can be used for 2 or more patients. So how are you effectively utilizing all the blood and blood products in your hospital is what we want to see. And ME6 is a new requirement where the hospital has a hemovigilance surveillance program. So they want a program now that monitors, investigates, sees any adverse events with blood transfusions or any near miss events occurring with the blood bank or the transfusion service. So this was a part of KPI, I think, in the earlier quality and patient safety chapter. But here now they brought it under these AOP and made it more specific, and the requirement is now there to comply with in the MEs. Sorry, 1 second. Yeah. AOP 5 to 506 is with new requirements for imaging. So lab and radiology come under AOP chapter, assessment of patients chapter. So the ME6 of 502 designates an individual to serve as the radiation safety officer that ensures that the service is in accordance with law, regulation, and policies, and monitoring compliance with radiation safety practices, like the oversight of the dosimeter, etc. Now, these again were under QPS and in the intent of the standard. Now it is in the ME. This is just like for labs. If radiology reports are not reported in the expected time frame, what is the corrective action that is taken? The hospital is required to maintain a copy of the license for all contracted radiology imagings. Radiology being a very capital intensive radiology investigation under the roof. So you may contract with either your sister hospital or with an outside hospital, and you must have a copy of the license that is from that in fact is a valid equipment which is and you're using these services by that hospital. Also, if you have contracted it from another hospital or another facility, ask them for what accreditation body they are accredited. So you are sure that you are tying up with somebody of equal quality of care that you are providing. Okay, so I am often faced with a question then, how can we ask them for their license, or how can, but you'll be surprised, if you ask, you will get it. So because everyone's proud of their accreditation, everyone is proud of what they do. So there's no harm in asking. Like I tell everyone, if you don't ask, you will never know whether you're going to get it or not. At the most, what they'll say, no. It's all right. Then you will look for somebody and you just tell them that I need it. I will look for another facility and send my investigations out there. That's all. And I was just talking to somebody earlier in the break that when we are faced with these situations where we have to contract with services, vendors, etc., achieving a standard of quality is going up, right? So whoever you associate with has to come up to your level. You don't compromise on your quality of care just because you want to work with someone else, right? So come, bring everyone up with you, your vendors, your contractors, everybody. You tell them that this is a compliance. We are all going to get better only by getting a stamp of quality and patient safety, right? AOP 6 is with the nuclear medicine services requirements. This is a new standard separate from the others. Again, we need a qualified individual to oversee this nuclear medicine service. Radiation safety protocols should be implemented, shielding, PPEs, monitoring devices, even evaluate the radiation doses that are administered to patients to optimize for diagnostic therapeutic purposes. Of course, the proper storage, handling, disposal of radiopharmaceuticals should comply with professional standards, laws, regulations, and patients and family are informed about these safety precautions. So these are also required in the regular radiology standards also, but we are applying them separately for nuclear medicine also. So the survey process would probably include what are the qualifications and training that you want in the qualified individual. Are the staff qualified and trained? What has the hospital determined, and do your staff meet those requirements? Review all safety protocols for all the the PPE and the monitoring devices that you have. How do you monitor the exposure of radiation? So these are questions that will be asked to you in the survey process to ensure that you are compliant with the standards. be able to discuss or show how your area has been designed, what are the disposal procedures, etc. So basically, whatever you outline in your policy, those are the questions that will be asked, and the staff should be able to demonstrate knowledge of these regulatory compliances. Going on to the next chapter, which is anesthesia and surgical care. So many of the standards are not new requirements, only there are few things which have been moved from the intent into the ME or from another chapter, and there are editorial changes. Otherwise, the ASC chapter is pretty much what it was earlier. But for those of you who are, there has to be a qualified individual that is in charge of the anesthesia service, and that person should be developing policies, procedures, providing administrative oversight, monitoring the QPS programs, reviewing and monitoring all anesthesia and sedation services. So the ME4, this has found itself here in this standard, the pre-sedation assessment performed by a qualified individual and documented. Sedation is given in parts of the hospital outside the OR. So first identify where all sedation is given. And by sedation, we mean moderate and deep sedation. Who is giving it? If it's not an anesthetist, then the person giving it has to be trained to give it. So some nursing staff or some medical staff do have that additional qualification to give sedation. So if they do have it, then in which areas of the hospital is it allowed? And that assessment should be recorded in the patient's medical record. And what is the content of this pre-sedation assessment and criteria for recovery should be outlined in your policy. The same thing for pre-anesthesia assessment and pre-induction assessment. These are based on professional guidelines. The care and monitoring is also according to professional practice guidelines. And if the patient has been implanted with a device, so this finds itself in this chapter, when you are using implants, identifying information on the implant and its unique identifier. So very often these implants come with a sticker or a label, and we find them that they are pasted into the patient record, and they are also maintained in a register for implants. So you should be able to track that implant, that this implant with this, let me just finish the sentence, is given to this patient on this day. Yeah, tell me. Sorry, can you take the mic, please? No, so that everyone else can hear you. It's not for me. Yes.
Sticker which has been placed after the implant has been placed inside the patient. So I need to know where all the stickers has to be placed.
It's up to you. What we want you is to be able to track it.
Okay.
So if you have to track that this device went to this patient on this day, no matter where you stick it, you should be able to track it.
Okay, ma'am. So we need, do we need to give it to the patient in the discharge summary that he has his implant?
A good idea to do so. I give it to all my patients who undergo an IOL implant. So that suppose the patient goes somewhere else, then person knows that this implant was into this patient. Okay. See, it's not a recommendation. It's not a JCI requirement. It's a recommendation. It's a good practice.
Okay. So, but it's not a mandatory thing.
1 minute. Let her finish. Yeah, tell me. I'm not telling you to do it. I'm telling you to find out a way to track it. I would think it's good.
Do it with sticking on the operative notes and over the OT
so
notes
also.
So
if your patient traveled somewhere or moved countries and or cities and needs to undergo an evaluation, would you be able to give him the data? if required.
In case if he contacts us, yes, like we can.
Yeah.
Yeah.
So it's just good practice to give it. It's transparency. I mean, if you want to, you don't want to, don't.
Okay. Thank you, ma'am.
The thing is, you have to, it's a preparation for product recall, or if there is something, the idea here is to be able to track it. That this particular device is implanted in this particular patient. I put the IOL sticker on the discharge summary and it goes with the patient. The prime reason that he also should know what is in his body, right? So most of the patients that I have gone with for other than eye surgeries, they are either given the box of the implant or, I mean, it's given to the patient, at least in India. I don't know.
Implants will come with a sticker.
Okay.
But the implants which comes without the sticker, what should be done? Like plates, screws will be there. So we have to sterilize, we have to send it to CSST for sterilization, which will not have a sticker. So in that case,
no, that will not have a sticker. That will only have the sticker of the sterilization done.
Okay. So then how it will be?
See, those are not, those plates and screws are not serial numbered and all. This we are talking about implantable devices to track which are, you know, which have a serial number. There is no plates and screws, according to my knowledge, if there are any orthopedics in the audience, they are of multiple quantities, right? Where I can put plate, this one or this one or this one. I just need to know there's a plate in the patient.
So that is not required, that sticker is
No, you will not have a sticker, no, for it. It's understandable. I'm talking about the sticker that is a unique identification for that particular implant, like all these hip transplants, intraocular lenses, I don't know what else
that we
is
have
implanted.
A sticker, but for the trauma cases, suppose for
pacemakers, yeah. So these are manufactured products which are come with a serial number. Those will have the stickers. But these plates and screws will not, na? They are in bulk. So you sterilize them. What we do in our hospital is that sterilization sticker is put into the patient record. So we know that the thing that went into his body was sterilized.
Thank you.
That process is what you want to follow, right? You should have a record that this patient got a plate and a screw or whatever, whichever kind of plate and screw went into his body. That much you must be able to track, right? Somebody, yes, sorry.
I was just saying that it is not the requirement, it is specifically prescribed by NABH to put it in the discharge summary as well. One in the patient report, one.
NABH requires that?
One in the discharge summary and one in the register. OT
so
register.
NABH requires it?
Yes.
Okay.
So maybe that is why.
Yeah, it's a good practice,
Yes.
I think.
And sometimes if we generally try to them to be triplicate, but if it is not possible, a Xerox of the same is also
yeah, some
can be
may
done,
not have three separate
yes,
ones.
that is why.
That's true. Okay. It's a good practice. So very often in Joint Commission surveys and consultations, we will not prescribe that you do it this way. We give you a recommendation as a good practice. You know, so it's up to you to take it on or not. This is for the lady. So so the patient receives information so the patient receives information. So the standard does want you to give that information to the patient. Identifying information, how long the long-term tracking of the device will be supported, process for notification in case there's a problem with that device, and education on sharing device information supports. Yeah, so exactly that's what I was saying, that it helps the patient, you know, in his long-term care to have that information with him when he leaves the hospital. So should he not come back to you and go somewhere else, he doesn't have to come back to you to ask. It's his implant, you put it in his body and he should have information about it. So yeah, I think I would take this opportunity to recommend that please give that information to the patient. So that's about ASC. Going on to medication management and use. A qualified individual oversees the medication management team. The interdisciplinary team is defined in writing, and now this is an ME now, okay? It was not in, it was in the intent earlier. Includes at the minimum a pharmacist, a physician, a nurse, infection control professional, and a hospital leadership. So these people have to be part of that interdisciplinary team. You may have more if you want, but at the minimum, all these disciplines should be covered. There are new requirements in the antimicrobial stewardship program. The focus is on the team, all components of the hospital that are responsible for use of antimicrobials. You have to collect, report, analyze and report data to hospital leaders. The program data is used to improve performance, and patients and family receive education on this program and the appropriate use of antibiotics. Okay, so the antibiotic stewardship program was there in the 7th edition also. It's just now collated under a separate standard with MEs focused on this on it. There is a new requirement on medication recall. So the minute there is a recall, anyone has any example of recall recently? Medication?
We had an explode wherein there was a contamination and we had to recall the whole batch from that.
Okay. Were you able to track which patients got it?
Yes, because it's all through
yes.
barcode, so we were able to trace it.
Trace it, okay. Yes?
ADR happens, ma'am, and in that case also we may have to
That's if you have evidence to prove that it was caused by that. No, ADRs you'll have to do a root cause analysis to find out. Yes, please, somebody raise, yes. Mike.
Here.
We had 3 adverse reactions to the same drug.
To the same drug?
Within few days.
Okay.
So the second, third day, we identified the batch and we recalled all those drugs.
So did you inform the manufacturer?
Yes. To the reaction thing also, as well as we withdrew all the drugs and sent it.
Yeah, but did you find out what was the reason for the...
See, before we wanted to go into all those things, the concern was safety of the patient.
Of course.
So we just recalled.
I know, you recall, but you must do an RCA to find out what was the real...
we have reported to the committee, the World Committee, you have the Pharmacovigilance Board of India.
Okay, great. Thank you. Yeah, so... Yes, please. Take the mic.
Reported with a couples of SSI infections, the same neurology surgery, who have done the endonasal procedures. And then finally with an RCA, we found that the nasal spray which is grown with some kind of organism, then we recall it.
Okay. Even though it was within expiry date?
Which is, we have done with the used one as well as the new one also, which is grown with some kind of Cepacia kind of organisms, then we recall it.
Okay, great. Good to know everyone's on top of it and taking corrective action. So these are examples of adverse drug reactions. You must maintain a record of what you did. You recalled the drug, you found out the cause, and keep a record of it, because this is what in a survey or a consultation we would like to see and know that you are aware, and the fact that you are analyzing the reason for these drug reactions, right, and taking corrective action to it. So then the next thing would be, so what will you do next time you are using nasal sprays? Will you change the firm? Will you change the drug? Will you... Okay, which is no growth. Okay, so you took a new batch and then saw it. Yeah, so that's an example of corrective action taken, that you will use it only not beyond 7 days of opening, and and check the batch. So that's good. That's a good example, right? Take the mic, please, because everyone can't hear. Yeah.
For the adverse drug reactions, we recently noticed even the Magnex 4, the commonest drugs, we were getting the reactions. So what we have developed in our hospital, the policy is, as soon as the reaction happens, we don't know whether it is a common brand that Magnex 4 is. So we developed a policy, the tryptase levels, serum tryptase levels, acute one, and that for that re-challenging it will help, because some of the commonest drugs also we were getting reactions, whether it is the transfusion reactions or it is actually the drug. So we started, we developed this policy. As you said, we had that interdisciplinary team, and then we developed this policy. That's what we did.
Excellent examples of how to work. Thank you for sharing. I can give all the examples to you, but when you share what you're doing, right? So that makes so much of a difference, right? Yeah, so so pretty much compliance with all the standards. Of course, this is specific to recall, right? But yeah, it's nice to know that everyone's on top of things as far as medication management is concerned. And medications that have expired have to be isolated, removed from the stock, and clearly labeled. I'm sure pharmacies follow this very stringently, but it is now a part of the measurable element. And all this documentation of actions, so even the expired medication, what do you do with them? Do you send them back? Do you discard them? Do you destroy them? Where are they kept? That is what we would like to see in your policies and practice. New ordering and transcribing requirements. Very busy slide. There's too much on it. All that we require is a diagnosis, condition, indication for use exists for every medication that you order. This was kind of understood earlier. It was not so well defined in the ME. And a written policy that includes the following type of orders. When is it a PRN? When is it a standing order? Stop orders, titrating, all these orders that are related, they were all from the intent of the standard, have been brought into the measurable element. If there's an order for a herbal product, if medications are discharge or transfer of patients, right? So these all need to be outlined. Where will we find them, and where, if there are orders for compounded drugs or mixtures that are not commercially available, what is your policy for it? Because I'm not siding doctors here, but doctors love to use whatever they want to use, and then they want you to find out that particular drug and give it to the patient. So you have to have a very robust medication management system to comply with these requests. A review is conducted when there are changes to the patient's level of care, unit, or doctor, including discharge planning. So every time the patient moves in your organization, a review of his current medication has to be done and documented in the patient record. We need to see evidence that, okay, he went from ICU to ward, medication reviewed. We went from the ward for an investigation, medication reviewed. Changed physicians or doctors or level, specialty of care, medications were reviewed, right? There are new standards for preparing and dispensing medication. MMU 5, ME4 says during preparation, staff visually inspect the medication for particulates, discoloration, or loss of integrity. So maybe this was being done anyways, but now it's in an ME that we will look for. You want to say something? But we will look for evidence of it being done. Now you may say, am I supposed to document it? Maybe, maybe not. but we will ask. So certain standards, we look for compliance by questioning. So when you go in various parts of the hospital, we question the staff that is actually administering. Here in this case would be the nurses. That what do you do before you administer this? And she should be able to say that I will visually inspect the preparation, and that would show compliance with this standard. So it's not that she has to write down that I visually inspected this. Okay, so not every standard has to be documented. There are various ways of seeing whether the standard and the ME is being met or not. Okay. There is this process to prepare them, to dispense them under supervision. How do you control for contamination? How are they transported, stored, packaged? And if they are packaged and labeled, to give the name of the drug, the dosage, the expiration date, and a radiation warning symbol. So some of our standards you will see are extremely prescriptive. This is one of those examples that we want to see all this information on a radiopharmaceutical drug. Okay. Some places will not be as prescriptive, but those critical areas, we do have prescriptive measurable elements. Safety for preparing and dispensing. The medication order review, this is a new one, includes variation from hospital criteria and impact as indicated by lab values. Now, what do we mean by that? We have to, this review process was being done at the pharmacy level, right? They review the appropriateness of the medication and it goes to the ward. Now, I am not sure whether this review will, this review over here, what is being mentioned here will have to be done by the prescriber that is now in the ward. The physician who prescribes the order will have to review it along with the lab values, and if there are any, if the pharmacy feels that there is any clarification required, they will contact the individual prescriber to before dispensing the drug. Record is maintained of whatever medication is dispensed, and the hospital will have now a written policy for medication labeling, which has to include the following information, like especially for those medications that are not immediately administered, if they are individual medicines for multiple patients, or when it is prepared by someone else other than the one who's actually giving the medication to the patient. So these are new requirements that have come into the ME of the standard. Earlier, they were all in the intent of the standard. Now, this is another example of a very prescriptive recommendation that is given in ME6 of MMU 6.00. Before administering a radioactive pharmaceutical for diagnostic purposes, staff verify that the dose is within 20% of the prescribed dose. Or if the dose is a range, then the dose to be administered is within that range. Now, this is a very, very specific requirement outlined in the ME. And another ME of 601, ME4 is, suppose the patient's or the family member wants to self-administer. So earlier it was that you can allow the patient to self-administer, the family to administer certain medications. Now it says you have to see that that patient or family member is competent. Now, how will you check for competency? Is you have to come up with that, whether the patient is able to understand, whether he's able to demonstrate. So that comes under patient education, right? They can demonstrate understanding how to administer the drugs. And obviously you should have a list that is, which you will allow self-administration. It's like eye drops or certain non-critical drugs. Not everything can be allowed for self-administration, right? So we have to use that discretion on which drugs we will allow and who will we allow, the patient or the family member, to give. It could happen for mothers giving it to the infants or children, and which ones will you allow that? So this has come up because a lot of places I had said that we should allow certain self-administration. So it was there in the intent that was allowed, but now we want you to assess competency for allowing self-administration. So we know what adverse drug events or adverse drug reactions are. Adverse drug events are those that are called. An adverse drug reaction is when the drug is correct, but we don't know that the patient is going to react to it. So there's a difference between an event and a reaction. Yeah. So there are a few requirements that have changed for ADE and ADR monitoring and reporting. ME2 says that the hospital follows a process for addressing prescriber notification. So how are you going to inform the person who has prescribed about that adverse drug event or adverse drug reaction? What is the process? And goes without saying, ME6 is saying conduct a root cause analysis. Now you've already shared with me examples. So obviously you all are already doing it. So you are complying with this standard. What is the internal external reporting requirement? Somebody said we have given it to the pharmacovigilance committee, the national level. Somebody said we have reported it internally. So, and all these events and reactions should form part of your quality and patient safety program. Okay, this data should be used, and this analysis and root cause analysis that you do should be used to improve your medication process. So like the person who had that nasal spray example, then they took another batch and they changed their process. They said they will use it only up to 7 days. They will visually inspect, they will see, and they will test the nasal spray, right? So these are the corrective actions that one took to improve the process to prevent this from happening in the future. And medication errors and near miss events. So medication errors is, it's an error that you have to define what an error is and what is a near miss. There should be timely reporting of errors and near misses. Action plan has to be developed in case it occurs, and how do you track them? And a root cause analysis, and again use of this analysis to improve medication. So we have adverse drug events, we have adverse drug reactions, we have medication errors, means it was really given in error, and we have a near miss. These are all 4 different events occurring, and all need to be tracked, monitored, and used, and the data used to improve the process. So that sums up the changes of medication management and use. Okay. Now, there are 4 more chapters where there are high-level changes, and this is the next section that we will go into. Care of the patients. This is regarding verbal orders and verbally reported test results. So they have found their way from IPSG2 into COP1. That's the only change. Everything remains the same. You have to have a process for verbal orders. When will you allow them? How will they find their way into the patient record? Who ordered them? And track the entry into the patient record. Verbally reported test results. So if you called and you got a verbal report from the lab or radiology or any other diagnostic result, how will you, and we had that write down, read back mechanism. So I call, you take the call, you write down, you read back the result, and the opposite person confirms it. That is the procedure to be followed, and we look for evidence of you having done it. there is a standard on clinical alarm safety. This was clinical alarms were, it was in the intent of the standard in the 7th edition, which is now in the measurable element 3. These alarm systems, policies, procedures, staff training procedures, they are to be reviewed at least at a minimum every 3 years. Not to say that you can't approve them earlier, right? So these are clinical alarms to, they are set onto the patient and take action, okay? So each hospital develops according to the patient population that it serves, what is the kind of clinical alarms that you need. There are certain criteria, if blood pressure drops or if this happens, every hospital determines the clinical alarms that they want to set. And why was this done? This was done to be able to intervene before the patient deteriorates, okay? So with experience and practice, the hospital knows that certain type of patients deteriorate, and these are the alarms that should prompt nursing and physicians to intervene earlier than what they would normally do. COP4 is dealing with resuscitation services. So the hospital performs an internal review of all resuscitation events for effectiveness. Okay, so this is a suggestion that in these areas, when you are analyzing any code that occurs in the hospital where you are giving resuscitation to the patient, these are the areas for improvement. So the timeliness of staff response, early warning signs, ACLS initiated, CPR quality, all these are the parameters that you will check to see whether the resuscitation service provided by you is optimal or not. COP5 deals with care of suicidal patients. So the hospital is required to screen all patients for suicidal ideation who are being evaluated or treated. A validated screening tool is required to be used. Now, it's not that every single patient you will choose. There is in the initial assessment, there are certain triggers that can occur where you need to send the patient for a detailed psychiatric evaluation. So which are the prompts, and once the patient goes, if there is suicidal ideation, then all these interventions come into place. An environmental risk assessment is required for possibility of the physical attempt, environment where a patient may attempt suicide or self-harm. And these screenings and assessments have to be documented in the patient's record. Continuing, it also says the hospital has written policies and procedures to address the care of patients who have identified at risk for suicide. Training and competence assessment of staff, guidelines for reassessment of patients, also includes monitoring patients who are at high risk. Also, written policies and procedures are required for counseling and follow-up care at discharge for patients who are at risk for suicide or self-harm. COP 905 deals with transplant services. This is now a completely new standard with new MEs. There are about 7 MEs in this, which I shall go through over 2 slides. All the hospital, if you perform solid organ, tissue or cell transplants, you will come under this standard. If you don't do any transplant, you say not applicable, okay? So now it's a separate heading. All data related to the transplant process is required by local or national networks, needs to be complied with. You have to have standardized written procedures for acquisition, receipt, storage, and issuing of all organs, tissues, cells. At the time of receipt of the organ, you have to identify that the package is package integrity is met, transport temperature range is controlled, and this verification has to be documented. Anyone from a hospital doing transplant? Oh, that's a large number. So I think it is very well regulated, actually, and most of these requirements I'm sure that you're already meeting. So it should not be anything new. If you feel there's anything new in this, it is very well managed in the country. It's a very high risk process. Hospital is to follow written directions from the manufacturer or tissue supplier for transport, handling, storing, and using the tissue. You have to have a process to track transplanted tissues, and all refrigerators, freezers, storage equipment used for storing these organs are at a controlled temperature and have functional alarms and an emergency backup plan. So you must identify that those areas of the hospital which require an emergency backup in case of power failures to ensure the integrity. These are highly sensitive. You don't get multiple organs very often, and how do you take care of them, right? So, yeah, that's okay. COP 908 is about clinical guidelines. The transplant program documents organ compatibility confirmation in the living donor's medical record. So if there's a living donor, you have to see that the compatibility of the organ that has been transplanted, that is recorded into the donor's record also. PCC is patient-centered care, and this is where we are talking about, in the beginning I told you that the hospital needs to identify the vulnerable population that it treats. Now, who are these vulnerable patients? They are disabled, chronically ill, elderly, children, adolescents, ethnic minorities, racial. So the hospital needs to determine who in your hospital is a vulnerable population patient. You may be having some of these or all of these or none of these, or at least you will definitely be having children and elderly. So you have to see which is that patient population that is vulnerable, that is seeking treatment at your hospital. So first you have the predetermined list, and then you have a risk assessment annually to see how are this vulnerable patient population going to be taken care of in the hospital. Do you have enough disabled, disabled-friendly areas where the patient can go? You have to, I'm not saying build ramps everywhere or do this. You have to evaluate on a day-to-day basis and see how you will serve these patients, right? And whether there are alternative ways of them gaining access to your hospital for the services that they require, right? And there is a written policy established by the hospital and how risks are managed for each of these vulnerable population patients. Sorry. This is also a new, some new MEs in this standard of clinical errors and how are they disclosed to a patient. This was not there in the previous standard. There's a written policy that addresses disclosure of clinical errors to patients. Firstly, you have to define what is a clinical error according to your. Now, if some hospital tells, 500 bedded hospital tells me I don't have clinical errors, we find that very hard to believe, because whether we like it or not, errors do happen. Whether we admit it or not, whether we'd like to talk about them or not, they are there. And that's what comes up through that incident reporting that we have, right? So find out what is a clinical error according to your hospital, circumstances under which you have to disclose it. Someday you may or you may not. Who is going to notify the patient about that error? And anyone else that must be notified on disclosure of errors. Also have an internal process to analyze and to prevent them from happening. Again, I'm not asking, please share your clinical errors, but there are sometimes, medication that looks alike, that the wrong eye or the wrong body part was given that drug, or it may or may not cause severe harm, but it is a clearly defined error on our part when we were treating the patient. So acknowledge it, go back to see your incident reports and try and find out the most common errors that you have faced and what are you going to do to prevent them from happening again, right? So it could be wrong medication, it could be a wrong test that was carried out on a patient. Of course, the worst one is the wrong site surgery, which I don't wish happened to anyone. Maybe informed consent was not taken when it should have been taken in time. These are clear errors that are made. And they may be few and far between, but we need to acknowledge them and we need to see that they don't happen again. So now there is a standard for clinical error disclosure in the 8th edition. Okay, moving on to prevention and control of infections. PCI 01.01 is the coordination of the infection prevention control activities. So the hospital defines the function and activities of how this is coordinated. Hospital-wide, time intervals for committee meetings, content and requirements of infection control guidelines, support staff throughout the hospital. ME4 was not defined earlier. It was just said that you meet on a regular basis, but now there is a defined, you need to define the time interval at which the committee will meet. Regarding equipment, devices and supplies, the hospital is required to use approved disinfectants in accordance with label direction, indication, how do you dilute them, when applicable, contact time, method of application. All these were actually found in the guidelines that one used to follow, okay? But now it's a part of the ME and we are required to see that we are in fact following the approved disinfectants according to this, and the use of agents and methods approved by equipment or device manufacturers. This continues. ME2 talks about the practices while performing high-level disinfection and sterilization of critical equipment, devices and supplies. Super detailed. So all these criteria were in the intent earlier or in reference guidelines, but now they are prescribed and put into the measurable element. So the use of approved chemical sterilants, required documentation of cycles that are used in the, you have the sterilizer cycle logs, frequency of chemical, biochemical testing, appropriate concentration of chemicals used. All this has to be defined as part of your infection control program. If there are discrepancies or conflicts, you have to resolve them. How did you resolve them? When will you use immediate use steam sterilization? All these were in guidelines earlier. They were not part of the measurable elements. So in which cases will you, if your sterilizer is not working, when will you use this steam sterilization? If there is a processing error or a failure identified, how will you, before you released that piece of equipment or whatever went into that, or any items, how will you reprocess them and give them, and you will need to document all of them. And qualified individual oversees cleaning, disinfection, sterilization, hospected and sterilized instruments, and a written procedure to identify and recall instruments for individual sterilization cycles and equipment. So, one second, and then, so one needs to ensure that the policies and procedures for this, managing these disinfected and sterilized instruments is really robust. If there is an issue found with the equipment later, we should be able to track it, when it was used on the patient and whether it needs to be, what were the reasons that were behind that incident that happened. And as far as possible, if the patient can be identified and screened if there was any contamination. This is my pet standard, reuse of single-use devices. I would never understand why a single-use device needs to be reused. But it is a part of our functioning. We do reuse single-use device. Why are they called single-use if they were not to be reused? I don't know. But yes, there are cost factors. There are certain devices that are not readily available, you see, and you can't just use them and give them. Maybe the manufacturer wants to make more money and call it a single-use device. I don't know. Those are my personal comments. But we accept the fact that single-use devices are reused. So if they are reused, we need to have a written policy and procedure of how we will reuse them. So first and foremost is identify what you're going to reuse. Then determine how many times are you going to reuse. So in your experience, if you know by 5 times I can't reuse this tube anymore or this instrument anymore, it's going to be discarded, whether it looks fine to use or not. So identify the single-use device, how many times. Sometimes it may deteriorate before you have used it 5 times, so you should know when it is no longer safe to use. What is the process for cleaning, disinfecting each, it's such a paradox, reusable single-use device? How will you track it to an individual patient? Now here's the challenge. Like, which patient got that reused single-use device? How many times? Like, was it at the first reuse, the second reuse? So I had this hospital which used to somehow mark them 1, 2, 3 or something, right? So you do that. And then the minute someone saw 5 or whenever it's supposed to be discarded, they would discard that. Okay, so you should be able to track it to the patient and collect and analyze data for adverse events. So sometimes you may have adverse events related to this procedure, which you should be able to track and analyze why that happened. Okay, and then probably improve the process. So every time you thought you could use it 5 times, but at the 3rd use it would deteriorate, then you would change your process to using that thing only thrice before it is discarded. So there are various reasons for this, and it's a fact of life that we do it, so then we have to manage it. Expired or damaged supplies. So there is a process to manage. I mentioned that earlier in the other chapter too. Medications like expired supplies, damaged supplies, how do you store them to prevent damage, and under which conditions they are stored. And if they do get damaged, how do you manage them? Handling of infectious waste. So there is a written policy to direct chain of custody for all body parts handled by pathology, mortuary, and other post-mortem areas. This was not in the earlier standards. This was a revision, and it's a new ME in PCI 5, where one wants to know what happens to this waste. What is the process for reporting exposure to blood and body fluids? So this has changed. Now it says the hospital uses an expeditious process for reporting patients. So saying that you need to have a process to manage the exposure which is timely. It is not something that, okay, I'll report it tomorrow, day after maybe. You have to see how soon it is, and that tracking log would be reviewed in a survey process. How quickly did you inform this, and what action was taken? Why did the exposure happen? And can you prevent it from happening in the future? And what did you do to manage the patient, staff, or visitors' exposure? PCI 7701 talks about transmission of infections. Staff are educated in the management of infectious patients. So one thing is, how do you manage this sudden influx of patients? And what does staff do? How do they protect themselves from these infectious patients when there's a sudden influx, or if adequate negative pressure rooms are not available? It's not an ideal world. Everyone is not going to be able to manage everything to the T. So we have to know how are we going to manage in these situations, and that is what we want the hospitals to have a policy on. And appropriate PPE and hand hygiene agents are readily available when needed. This was there in the earlier standard also. What is the hospital's preparedness and response for high consequence infectious disease or special pathogens? So one may think this is same as global communicable diseases, but there is a different policy for that. This is like sudden influx of patients. What will you do? How will you screen them, isolate them? Do you need to inform public health authorities? Do you have enough PPEs? Are staff trained? And how will you reduce exposure to other patients, staff, and visitors in such cases? There must be a this standard basically complements the emergency management and the global pandemic emergency standards, and they are not duplicative, okay? So this one focuses on screening, isolation, informing public health, key staff, PPE, waste management, cleaning, and disinfection in this PCI chapter. And that is dealing with the whole program as such. How will you manage the patients? How will you see? How will you isolate, etc.? The hospital also implements education, training, and assesses competencies of staff who will implement these protocols. How do you coordinate with transportation services and local public health authorities? Those who are exposed to this infectious disease or are suspected of being exposed, how will you manage them? And what is the plan for vaccination of all staff, leaders, healthcare practitioners whenever applicable? PCI 801 is how do you communicate information and data from infection prevention control program to leaders and the governing board. What we would like to see is that evidence of maybe the meeting minutes to the governance or the board as to where this data has been conveyed to the hospital leaders from the infection control program. There are a few more slides on one. Yes.
this is regarding the antimicrobial stewardship program, where it was mentioned like it should be discussed in a committee. Right.
Right.
Things related to antibiotic stewardship program (AMS) should be discussed in a committee.
Yes.
So there are two committees. One is pharmacy and therapeutic committee or pharmacotherapeutic committee and control committee. So there is a conflict, like the infection control officer says it's the baby of the clinical pharmacologist, and the clinical pharmacologist says it's the baby of the infection control team.
I think it would be with the multidisciplinary team, which is definitely the infection. But you do need the pharmacy there also.
Okay.
Yeah, because we are seeing the use, right? The clinical use of the. It's not only the drug. It is the way it is used, who's using it, on which patient population. So now you can use my name and say it, which I would prefer you don't. But please use your discretion. Tell them, understand it. So don't pass it on. I would say both meet. Yes,
ma'am. Ma'am, do we have to take the consent for reuse devices for the patients that we are using?
Oh, good question. It just shows everyone's awake, which I'm very happy. I think it doesn't have to be a separate. Hello. Important question here. You all heard the question, right? I don't think it needs to be part as a separate consent, but it can be a part of the surgical consent that certain reuse of single-use devices may be used in your surgical procedure. If you make it a separate consent like that, you'll have to have how many consents, right? So no need for that.
Is there any legal consequences for that? What if the patient catches any infection after that?
But that's the whole idea, no? That you're not going to use those kind of devices that will have this risk. So currently, let me ask a specific question. Do you have a list of devices that you...
Yes, ma'am, we have.
Yeah. Have you faced any issues in the last 5 years?
As of now, no, ma'am.
Okay. So this list needs to be really concise and small. It's not like every single-use device that can be reused just because you want to. So let me go back one step. I would want you to analyze why are you using this device again, okay? To me, the two main reasons is cost and unavailability, okay? So they are the two main reasons why we would reuse that. Is there a third reason? Not just because you want to save cost on everything. Oh, come on, we came from an era where every needle and syringe used to be sterilized before use, and we have come to that. So we're not going and saying everything that can be reused will be reused. No, that's not the logic, okay? So it's usually cost, or it is really non-availability, yeah, which is causing this. So I don't think you need a separate this thing. Normally in our consent we say that, or a general consent we say that you may be examined by students or by trainees, or there's that whole paragraph that comes. And if there is a particular instance where you want to inform the patient, you can make a note of it in the record that patient was informed. Some patient may say, no, I don't want you to use it. Then you say, okay, will you buy a brand new one which costs so much, right? So I think these are also ethical concerns that come in your organization. And I think it should be dependent on the number of devices that you're reusing. Normally it's a standard thing all over the world that certain things are reused, okay? And they are reused once, twice, thrice. And that's the whole thing of tracking. Now, if you find that a particular thing is giving you an adverse reaction or something in the patient, then stop using it more than once, I would say. So this is the whole ideology, is to track and monitor this. If you start taking an informed consent, no one will sign it only. They don't sign it, you will say, you didn't inform me last time. There are a lot of procedure where it is commonly reused. By all means, inform the patient and write it in the record. But I don't think you need a separate consent form for it.
Thank you, ma'am.
I think it was a very vague answer, but so, yeah. Yeah, please.
Ma'am, PMJY scheme launch in India.
Pradhan Mantri Yojana.
And insurance company. Because ma'am, I'm looking both part operation and business along with the cost cutting.
Okay.
So nowadays insurance company are not giving the certain device charges. Like device closing for the pediatric patients for the congenital delivery system, every time we cannot use new. IIBP balloons, PMJY is not giving the IIBP balloon charges, and balloon costing around 40,000 rupees, and balloon is not getting inside the market. And maximum use 3 times is after that you cannot use.
Cannot use, yeah.
I am seeing the guiding wire repeatedly used in the cath labs.
Right.
2 cases in front of me, the wires catch inside the coronary, go for the CABG surgery for removal of that wire. So, if and buts, that is ultimately depend upon us, CSSD department plus technicians who looking after the.
Right.
That is the persons who can decide better than clinician, and along with that, as per the recent in NABH, they also tell directly that you when use the reusable device, then you have to take the consent, because anything happen, then.
So what I said is, don't take a separate consent, like a separate
but
consent form,
included inside
but inform the patient.
Included inside the case, sir, the consumable items, certain consumable item we can reuse during the procedure. Like in cath lab, every time you cannot use new guide wire or the PT cable.
True.
So that I would always alternative solution for that. And it's every time picking up the year old. Anyway. Thank you.
Yeah. Thank you. Okay. Yes.
This is regarding an ASMP antimicrobial stewardship program.
Yes.
Is it a mandate that we should have a separate committee for that? Because we discuss in our Hospital Infection Control Committee, and pharmacist is a member of it.
Yeah, that's fine.
That's fine, no, ma'am? Or we should show it separately as a separate committee or subcommittee, something like that?
No need.
That
we don't need to.
Minutes can be minuted in the HICC itself, and we can show it.
Yes.
Thank you.
Done? Okay. QPS now. Certain changes in the QPS chapter, not changes, additions. Sorry. Yeah, I just have about 3 slides left. So I'll commission, then we'll take a tea break, okay? Okay, tea break coming up after 3 slides, or 4 slides. Okay. Incident reporting. So this, I referred to this earlier. There's a new ME6 where you implement measures designed to encourage patient safety event incident reporting by staff. I referred to it earlier. And we will see that you have measures in place to improve this reporting. And but you don't have to show the evidence of improvement in incident reporting. I was just giving you an example that I used to just show it to my staff so that to encourage it. So this is one change. Oh yeah, actually this is the last slide. Like I told you in the beginning, the Sentinel event policy is not there anymore. It has been moved to it's no longer scorable in initial and triennial surveys. Surveyors will not be asking you anymore that did you have a Sentinel event and what did you do about it? But will definitely ask questions about the overall process. So what is the you must have a policy, conduct an analysis, and you must have a process to actively support employees affected by adverse events. This we have already covered in the past. This pretty much brings me to the end of the discussion on chapters that have high-level changes. Again, to say that we have not covered each and every new standard and measurable element. It's impossible to do it in a day. We break for a tea and we have a session by me and by Arjun later to talk a little bit more about the changes and additions to the survey and accreditation process. And thank you so much for your attention, and we are here to chat with you some more. Thank you.
Okay, why don't we go ahead and start? This is the last session, so we want to get you all home soon. So I'm just going to talk a little bit about some of the innovations. So this is not related to the actual standards, but these are changes and innovations that we have made overall in the survey process. And so I'm going to touch on a variety of different aspects of changes that we have made to the process that we do. Just like all of you at Joint Commission, we believe in that our process needs to be continuous quality improvement. So we are always listening for feedback from our customers, wanting to know and so all of these changes that I'm going to cover today come from suggestions that have been made by people like you. So when you have suggestions, please share them with us so that we can continuously work to make the accreditation process better. And I'm going to start with the brief discussion of the continuous model. You've heard a little bit about that, and we think this is a really important step forward for accreditation because, as many of you have been saying, this is kind of the cyclical nature of what happened in accredited facilities. There would be a lot of work preparing for the triennial survey. Things were put into place. The systems were really robust. And then over time, the next 3 years, things began to decay until it was time to get ready for the next survey. I have a colleague who jokes, he says, I wish my hospital every day was as good as we are the day before the Joint Commission shows up, because that is the best the hospital will ever work, and then it just steadily worse after that. And that's not what any of us want, right? We want the hospital to function at the highest level all the time. And that was the rationale behind developing a continuous model. The desire was to have ongoing and continuous engagement with the facility so that standards would remain high throughout the accreditation cycle, not just right before the end. And in fact, when we began asking a lot of experts, our clients about this, there was a lot of support for this. Many of them said, yes, we think that continuously engaging with the Commission would be very valuable. We value time with the surveyors to have that back and forth discussion about our processes, our practices. And so having a regular process, a continuous cycle, really would be advantageous, provided it can be done without raising the costs of the survey. And so that was the rationale behind creating this new continuous model. So now, instead of displaying the accreditation cycle as an up and down process, it's displayed as a circle because it's intended to be continuous. We still have triennial survey, but in between the triennial surveys, there are now what we call touch points. So every 6 months, we will be interacting with you so that there is a continuous discussion between Joint Commission, International, and the facility. And this feeds this new model where we want to be partners. We want to be collaborators with you improving care. And the best way to do that is to stay in dialogue with you on a regular basis. So the formal survey will continue to occur every 3 years. However, I'll show you some details. The surveys will now be a little more streamlined because if we're interacting with you every 6 months, we can tailor the survey because we've already had regular interactions with you. And then in between the surveys, there will be 5 points. Every 6 months, we will have a touch point, and those are not part of the accreditation. So this is really a very open forum where you can discuss anything you want with Joint Commission. You can bring your concerns. They're not part of the accreditation decisions, and they're really tailored to whatever you want to discuss. So this is intended to be an opportunity for us to collaborate on the types of things that are of importance to you and the things you want to talk about. We developed this continuous model, and then we piloted it with 3 facilities just to see how they felt about the new continuous model, and the reception was very good. They felt like the continuous model really did lend itself more to a collaboration and partnership rather than coming in as more of an audit and box checking exercise. They felt like there was a lot more actionable information that they could get from this regular interaction. They did provide kind of a couple of opportunities for improvement to be sure that there's consistency between the different surveyors. In general, what we try to do is have the same surveyor who did your survey on site do your touch points. That's not always possible, and so we need to make sure there's consistency across the different surveyors. And they wanted to see a little more clarity in the touch points, a more structured agenda for the touch points. But overall, they did point out that there were a number of benefits. The survey is now more streamlined. The survey is much more focused on tracer activities and the surveyors being out in the hospital, and less time with surveyors sitting in a conference room looking at a computer or having meetings. They liked the option of having the touch points, the regular discussions. They liked the streamlining of the reapplication process. They continue to be supportive of the 8th edition standards. And the model now, the costs are the same. So even though there's more interaction between Joint Commission and the facility now, the costs were the same. And so that the people who piloted it really liked that as an increased addition to the value of the accreditation. So there are some revisions to the triennial survey. And I'll share a little bit about these. I have some details on the tracers so you can see how some of the tracers have changed. So some of the things that used to be presentations, right, where we sit in a room, you would give us a presentation, now some of that has moved into a tracer. So rather than a presentation, the information is discussed during the tracer, which increases the engagement with frontline staff, which is certainly what we want. There's the leadership ethics and global health impact tracer is combined. There's a lot less time now that surveyors are independently working, looking at records, and more time with surveyors spent interacting with staff. And the surveys are now going to be a little bit shorter because of the touch points. A lot of that background work has already been addressed. So here are some of the changes to the different tracers. So the leadership session tracer will now include some discussions about culture, ethics, and global health impact. Right? Those used to be presentations. Now there will be discussions during the leadership tracer. The supply chain discussion will move from a presentation into discussions during the facility management systems tracer. The quality and patient safety tracer will have some discussion about some of your data initiatives, and then a lot of that discussion will continue then into the tracer. So moving what used to be purely a lecture-style presentation into the tracer activity. The antibiotic stewardship discussion will remain in the pharmacy tracer, but there'll be more interaction and more review of medication management during the tracer activity. The prevention and control of infection tracer will have a brief discussion about the data, your surveillance data, current initiatives, and then again, those discussions about your data and initiatives will carry into the tracer so that more of that is being done with frontline staffs out of the conference room and out in the hospital locations. And finally, we've removed the patient group interview tracer, and now during the other tracer activities, the surveyors will be interacting and having discussions with patients so that, again, we've moved that one tracer and we will incorporate that to the other tracer activities. So we're hoping to make the tracers much more efficient. For the touch points, there will be 5 of these touch points. They occur every 6 months between the surveys. And like I said, the goal of the touch points is for you to really inform and drive that agenda. This is an opportunity for you to discuss the things that you are working on. What do you want to discuss with Joint Commission? And so the Different topics that you could include might be infection control, mortality, morbidity and mortality, your quality improvement efforts. So they're really intended to be very open, guided by what you would like to discuss. And then that final touch point number 5, which will come about 6 months before the triennial survey, is a slightly longer touch point that allows us to get ready for the survey. So we can do a lot of the preparatory work for the survey, so that will also then enable the survey to be much more efficient because we've had some time to really prepare together and plan for that survey. So those are the changes. That's what you will see as being different in the continuous model. But I want to share also a couple of changes that you will see in the outputs of your survey. And the first is the ability to do peer organizational benchmarking with your survey data. You always get, when you get your report at the end of a survey, we will tell you that you had a certain number of requirements for improvement. But what people really wanted to know is, well, if I had 23 requirements for improvement, is that a low number? Is it a high number? You know, does that mean I did really well? Did I do really poorly? They wanted to be able to benchmark against others. And so now we have created in the same part of the application where you see your results, you now have the ability to do some benchmarking. And you can custom create whatever types of facilities you want to benchmark yourselves against. It comes with some defaults, but you can set it up to be, if you want to look at yourself against other hospitals in your region, you can adjust by bed size, you can look globally, but it will basically give you a histogram, and it will show you where your survey results compare to the other facilities in whatever cohort you have chosen, and will allow you to see how your survey results compare and help do some comparative benchmarking. So this is something that people have given us a lot of feedback about. They wanted the ability to do some benchmarking, and now that exists in the reporting system. The other changes that have been made to the way that we give reports. In the past, we gave the SAFER matrix report, and it only had the standard numbers that were listed there. And people said, you know, that is really, that's confusing. When I go and when I show people, you know, it has this one, it's, you know, the MM01 ME3. Well, what does that mean, right? I don't know what it is. And so now it's a very simple change, but it's a very popular one. We're putting the description beside each of the standards so that you know, oh, that's the antibiotic stewardship standard where I had the citation. And finally, again, based on feedback from our clients and customers, we have changed the survey reports. And so in the past, survey reports were very text heavy, and people, you know, it's very hard for me to take a quick look at the report and really understand the types of things that I want to work on. So now we've really worked to try to change the report to make it much more concise and much more focused so that you can pull key highlights out of the report. The details are still there, but it's better summarized to make it much more actionable. We changed some of with the continuous model, the way the surveys happen, we changed some of the reporting elements. And I'm closed by talking a little bit about an entirely new part of the surveys, and that's the Safest initiative. This began just this past February, so it's a relatively new effort, but it really is intended to identify what we call performance strengths, to really bring forward things that hospitals are doing well. So why are we moving forward with this? Well, we know there are a number of things. Every hospital has things that they do extremely well. And we would like to capture those, both so that we can recognize the hospital in a formal way to tell the leadership of hospital, while we were doing your survey, we noticed that you had a really good process for medication management or for antibiotic stewardship, infection prevention, suicide prevention, whatever it was. We want to be able to provide some formal recognition back to the hospital of what was going well. We also know that healthcare is a learning community, and we want to learn from each other. So we want to be able to capture all of these things that hospitals found innovative solutions for, things they're doing well, so that we can share them with other places and we can begin to learn from each other by building a catalog and a database of these performance trends. So maybe you do medication management really well, but you struggle with your infection prevention. Well, now you would be able to go to a database and look to see, well, who is doing a really good job with high-level disinfection. And I can reach out to them, talk to them, and understand what they did so that I might be able to strengthen that practice in my hospital. So we call these performance strengths. And these simply are things where our surveyors are on site. They are practices that the surveyor is impressed by, that's something that they notice that where the hospital is doing a really good job. And so in the past, people said, well, you know, the surveyors, they all central, your sterilization processes were really good. Now, they'll actually, the same survey tool where they would note the requirements for improvement, they now have an opportunity to note a strength. And they can capture a little bit of information right there in the survey tool about what the strength was. So when they generate the report at the end of the survey, there's both a narrative listing of the areas where improvement was needed, but also a narrative about the things where the hospital is doing really well. How does this change the way the survey works? And this is the beauty of this, is it doesn't change it at all. SAFEST builds on what we already do. Our surveyors have been telling us for years, when we're there is seldom a survey that we do where we don't note something that the hospital was doing really well. And we've always been noticing that, but we've never had any way to document or capture it. So all we could do was tell the hospital, yes, we noticed this thing you do really well. So this gives the surveyors the ability to capture those strengths and report them back and share them back not only with the hospital, but also share them with the broader community of accredited facilities. And this will give us that opportunity to really begin to learn from each other. So now, in addition to getting the SAFER matrix at the end of your survey, if your surveyor noted a performance strength, you will also get a SAFEST report. So you will get one SAFER matrix report that notes all of the requirements for improvement, and your leadership will also get a SAFEST report, which summarizes the strengths that were noted during your survey. But that's not where it ends, though, right? Because now that those SAFEST reports and all of these performance strengths are then relayed back to us at the central office. And what we are doing is we are reviewing these performance strengths. And when we see performance strengths that we think could be useful to other hospitals, that we think might be something that other hospitals might want to use, we are now reaching out, we are emailing or calling those facilities and saying, would you be willing to talk with us a little bit and give us more information about what you did so that we can build a resource to put into a central database of Joint Commission. And as we're gathering these summaries of these performance strengths, we will build this database that then will allow anyone to go and see, if I had a requirement for improvement in an area, in the blood bank, for example, I could go to this performance strengths database and find other places that had strengths in their blood banking and learn and see what they did so that I can replicate these practices. The performance strengths, we're building them in a very standardized way so they will all look the same. They will have a brief overview. They will give you an operational plan. They will give you the results of what they did. They will talk about how they're sustaining their quality. And then there's the ability. So every facility that is willing to have a performance strength is also willing to be contacted. So you can not only read what they did, but you can actually connect with that facility through email or even a phone call and have a discussion with them to learn more. So this really, we think, does create the opportunity now for our accredited facilities to truly become a learning health system, learning healthcare network. We've been doing this for a couple of months. We've had a large number of performance strengths submitted. We've already had over 200 different performance strengths noted on survey. And this is just a very short list of some of the things that our international surveyors, our JCI surveyors, have noted. For example, there were processes to assess the patient experience, an automated clinical outcomes program, a very good handover process, patient information boards, nursing professional practice models, and a strong backup plan for information technology security. So you can see that our surveyors are noting these strengths across all of the different standards areas. We are capturing them and creating these summaries. And once we have enough of them, we will put them into the database where anyone can access them. As part of SAFEST, we're also working to release educational content. We are trying to tackle the areas where we note the highest number of high consequence requirements for improvements. So we're in a way that analyze them on the SAFER matrix, looking for those high impact, the most dangerous requirements or improvements, the most dangerous observations, and we're working to try and develop resources, training and education to help people address some of these really important areas. And we're doing that, we're producing some very short videos that cover what the standards are, talk a little about the most common requirements for improvement that our surveyors note, and then a very brief summary of the types of things that you can do to address the requirements for improvement. So we have 2 of those videos that are now posted on the Joint Commission website. One is on high-level disinfection. There's a second video on sterilization, and we now have 2 videos that are in development on suicide prevention. So these are intended to be very short. They're high level, but they're a good introduction to that topic, and they give you some key questions to ask of your systems to see if there are areas where you would want to improve. So we are always open to feedback. As I said, all of the innovations, all of these changes that have been made, these improvements to the process, were made by people like you who interact with us, who make these suggestions. We are always open to suggestions, be it on the continuous model, on the way that we give your reports, the SAFEST initiative. If you have any comments or suggestions for us, we welcome them. You can email us. We would love to interact with you and to hear more from you. And so with that, I will close. I know it's probably about 4 o'clock, so we're kind of at the end of the day. So what I will do is I am here, I was here, we can take questions if you have them. But otherwise, I want to thank you all very much. You were an incredibly engaged group. It was a long day with lots of slides, with lots of words, but you guys really focused, you paid attention, and interacted with us, and we really do appreciate it. So thank you all so much. And I think the certificates are outside there. So if you want to stop and pick up your attendance certificate, they are all outside there. Yes, please.
Cancer Institute, another was a urology, both JCI accredited. And they are doing fantastic in some of the, maybe the medication management, maybe some other aspects. And when we go for this touch points, definitely we share these things to both the hospitals, but it may or may not be applicable to both the hospitals.
Absolutely.
And because the challenges are different, their patients are different.
Yep.
But definitely in the long term, JCI will have a very good data, and with the help of AI tool, they can generalize it to a particular country or particular region.
Right, right. And thank you for that question, and the goal for these summaries, they're really not intended to kind of be generally applied. They're really intended to be very specific. So you'd be able to assess and see if you are looking to improve, for example, titration of medications. You can look and see, are there examples? But you're right, you would have the ability to read that summary to understand, is this directly applicable to my setting? Or is it something that's very different and it probably would be applicable to me? Because you're absolutely right, they have to be contextualized.
For reference, it is very good.
Yeah, thank you. All right. Okay. Well, we are here. If you have questions, please feel free to come up. And otherwise, we thank you so much. Are there any other announcements or anything from you all? Or yeah, come.
Okay. Good evening. Thank you, Dr. Shroff, for taking us through the JCI 8 edition standards and especially highlighting the implementation requirements. And thank you, Dr. Srinivasan, for explaining about the continuous model. I'm sure we all have learned something new, and we'll be taking back all this to our hospital and we'll be implementing in our own hospitals. Thank you all for joining with us today. Our certificates are available in the reception. So when you move out, please collect your certificates. And once again, thanking CAHO and the entire crew for being with us today. Thank you.